I am going to call this meeting to order. This is the March 9th, 2023 PEB board meeting. Good morning and welcome everybody. This is our first regular board meeting since our retreat, and our meetings are going to be hybrid going forward. Healthcare Authority staff will be on site as much as possible, and other attendees, both board members and the public, will have the option to attend either on site here in Olympia or via Zoom. For our Zoom attendees, our opening slide has information about how to turn on closed captioning subtitles. And please, just everybody, please be patient as we keep honing these hybrid meetings and as we keep modernizing the equipment and whatnot. And we welcome your feedback too. It was members of the public that helped us move forward on the closed captioning feature. So please, we're in a lifelong journey of moving towards more hybrid permanently, and we want to get things right, so we welcome your feedback. So first I'd like to do a board member roll call, and we want to identify the board members who are with us today. So I'll call on Monica McElmore, please. Are you present?
I am present.
Thank you, Monica. John Comerford.
Here, present.
Thank you, John. Harry Bossy.
Yes, I'm here, present.
Thank you, Harry. Michaela Dolman is here in the room with us. Go ahead.
Present.
Thank you. It's great to have that voice recognition for those that are listening in. Tom McRobert.
I am here.
Thank you, Tom. Kurt Spiegel.
Present, thank you.
Awesome. And Elliot Weinstein. Elliot, can you come off?
No, I unmuted, present.
Thank you. Also, Michael Tunick from the Attorney General's office. Are you on with us this morning?
I'm on. Good morning, Chair Birch.
Thank you so much. And I'm Sue Birch. I'm the chair of the PEB board. With board members attending both in person and virtually, it would be helpful for the board to hold their questions until each presentation is complete, or when the presenter pauses and asks if there are questions. Board members, we will also watch in case you use your Zoom's raise your hand feature to indicate you have a question. As done before, there are times where you can't get to that quickly and you've used your manual hand. We'll be watching the screen. So again, please be patient, but board members, please let us know that you want to jump in. For the public, you will have an opportunity to provide general comments at the end of the meeting during the public comment period. Other things here in the room, thank you for those of you that want to wear masks. We also are comfortable for those of you that don't. That is, again, we just endorse individual decisions about that. All right, Dave Eisminger is going to take us into the overview of today's agenda. And Dave, let's see, is there anything? Oh, you're going to talk about where our bathrooms are located and movement in the building. So go ahead.
Yes, good morning, Chair Birch and members of the board, Dave Eisminger. Today we're going to start off with a little bit of time traveling and talk about and have bring before you the minutes for the entirety of the 2022 board season, as well as I'll share some information about a different approach that we think should be taken on minutes in the future to try to be more timely, as well as giving access to audio files in a timely manner. Then there'll be some just general follow-up questions. I kind of do a cleanup of things that don't quite fit nicely in other presentations for some of the questions that came up at the retreat. Then we are going to have your first vote of the season, which is action on a bylaws amendment, which relates to how public comment is handled during these meetings. And as a reminder for the public, there is always an opportunity for public comment during the motion process before action is actually taken on an item. That's in addition to the general public comment that's at the end of the board meeting. Cade will update us about the bills that are in the legislative process. There was a cutoff yesterday from the House of Origin, and so he'll have some even more real-time information that what I'd say is have your pens ready, because there'll be some things to note on the slides of some bills that are no longer active in the legislative process. Molly Christie from our finance department will be talking about just general financial insights about the program. This is also something that we've been doing with the sub board, and so wanted to do just an overview of program finances for the board. And then we're going to level set on some hearing instrument benefit data. There's been a lot of utilization of hearing benefits that exceeds the projections that are originally modeled for the program, and we wanted to share some information about hearing instruments. There's also a bill traveling through the legislature on hearing instruments for employees' independence. So there's a couple of moving parts, and we anticipate that there could be action or discussion for action this board season relating to the hearing benefit design. And then Ellen will join us. There's always some things to share about Medicare and our work with our Medicare retiree population, including those engagements that are beginning in earnest soon to have our listening sessions with a variety of PEB retirees. And then the March meeting is where our Rules and Policy Shop brings forward proposed resolutions on the eligibility and enrollment process. We bring those to you every year in March and then ask you to take action on them in April. So this is the introductory phase. Again, it's really a good reminder for everyone who might be new to the board meetings or processes that we have a strong tradition unless there's an absolute emergency. An example being COVID was an emergency. We try to have resolutions introduced at one meeting, get general introductory discussion from the board, and then we put those out for stakeholder review and then bring them back, and they may be refined during that process, or they may even be pulled or tabled as a result of that stakeholder process. But this is the introductory phase for those eligibility and policy rulemaking. And then we will move on to general public comment and adjourn for the meeting. I do want to highlight a couple of more operational things. Our bathrooms are, if you go out the back door here and head down the hall, you'll see a water fountain, turn to the left, and the bathrooms are on the right. If we have an emergency and need to evacuate, everybody heads to the parking lot that I'm pointing to over my left. Sorry if the visual doesn't work for those of you online, but you would not be evacuating with us. So hopefully everybody here knows where we're going in either of those needs. I'm going to turn it back over to you, Chair Birch. I do want to note that there's a hand raised from someone in the public, and I don't know if you want to identify if there's a technical question or something, and so I'll hand it back to you, Chair Birch.
Thank you, Dave. For the member of the public with their hand raised, could you identify yourself and just let me know why your hand is raised, please? And the hand raised is not coming off, so I'm going to assume it might be a button that has been hit mistakenly, and that hopefully for you that are listening in, this person, if you could know that the public comment period will be later in the period. I think the hand signal just came down. So thank you, and we'll keep monitoring. Okay. One thing I wanted to also mention in my opening comments, and I forgot, I apologize, it's a little bit of my cold brain. Dave and I were in Washington, D.C. last week, and we were very fortunate to take our concerns about kind of the evolution of Medicare and the complexity with retirees to the CMS administrator, Chiquita LaSure Brooks. And I wanted to just mention that because there is an ongoing conversation in this nation about all the moving parts in healthcare transformation. And so we were very pleased that there was an open door policy and an hour was spent, and Dave did such a nice job representing our challenges and our pursuits of really trying to maintain affordable, comprehensive, high-quality services for all members. The second thing that happened for board members that you need to know is Dave and I also journeyed over to the National Academy of Science, Engineering, and Medicine, where we represented the state of Washington on a forthcoming report around healthcare in the U.S. about some pivotal directions. So just know that we spent a lot of time in Washington, D.C. on PEB's behalf and the state of Washington's behalf, and I do think you all should really welcome the notion that our voices are heard and our comments are integrated into the ongoing healthcare reform journey. So Dave, thank you. You were beyond professional and helpful. And Dave will continue to represent these topics going forward. And I know, Dave, you're going to say, it's my team. I want to recognize you, though, individually and your entire PEBB team, because you do a great job. And it's wonderful when we can create those linkages and networks and try to get more of our needs met for our members.
And thanks, Chair Birch, and for the board, I'll share a little bit more comments about that meeting when we're in Ellen's presentation as well. So don't think that this is the last time we'll talk about that meeting today, but I'll receive my comments for during Ellen's presentation.
Yeah, these days you can't say thank you enough. So huge gratitude, Dave. All right, let's move into our first agenda item, which is the approval of meeting minutes for the 2022 board season. Today, we're going to vote on 7 sets of meeting minutes for 2022 PEB board season. There'll be a vote for each set of minutes. These minutes are behind your tab 3, and they are separated by the goldenrod sheets of paper. Before asking for motions on the minutes, Dave, can you give us some insights about the change in approach for the board minutes?
Yes, thank you, Chair Birch. I'm glad that we're bringing you all of 2022's minutes. It is not my preference to bring you all of 2022's minutes in March of 2023. And so I just wanted to talk a little bit about, for folks who have historically looked at the minutes and then look at this set of minutes, some transitions that we're trying to do. In the past, we've had something that was more akin to, but not actually verbatim minutes. They were quite voluminous, very detailed. Many people, if you read them, would have thought that they were almost virtually a transcript that a court reporter might produce. And the reality is that has proved to be just kind of an unsustainable business model. Connie did an excellent job as the work expanded with a second board, and we were having multiple meetings and constant meetings trying to keep up and trying to balance speed and accuracy as that work has doubled was really just has proven to be just a challenge that I think we need to do a different approach. So as we were coming into this board season, we went over what the legal requirements for minutes. Minutes are typically more summary in fashion. There's not a specific requirement for the content of minutes in the Open Public Meetings Act. We consulted with other staff here at HCA that support public boards as to the production of their minute process, and so we're kind of proposing a new approach. The first thing that I wanted to highlight that we've already changed is we're going to post the audio recordings that we make as these meetings are occurring in real time up on our website. And in fact, when we started on this journey of a new approach, we posted all of the 2022 audio files for April through July back in sometime in mid to late January of this year. We just identified that the March ones had not been up, but I'm understanding that they are either up as we speak or will be up by the end of this meeting. But we wanted to get that information up as we were then bringing you these draft minutes. Those audio files are in the same place that we publish the briefing book in advance of the meeting, and the same place where members of the public go to access the Zoom link to actually attend the meeting in real time. So you'll be able to go back on our website and see both the briefing book, the audio file, and then after minutes are approved, the official minutes that the board approves. Our goal will be to, within a week of the meeting, have the new audio file up. So for example, the file that's being made today of this very meeting, our goal would be to have it up by the end of next week. And then we would bring minutes to you at the next meeting, again in a more summary fashion. Jessica really is going to be working on what are summary minutes. They're not going to look like direct quotes. They're going to look even a little bit different than the set you have here that was trying to balance and transition from that verbatim almost setting into this more summary fashion. Jessica will have the set for this meeting available, and we'll have them brought to you at the next meeting. And we'll be really interested in your feedback as to whether you think it's calibrated to capture the detail in the right level. Some of the things we're going to make sure that are in those summary meetings are if there's any corrections that happen in real time on slides, we'll make sure things like that are clearly documented in the minutes. Jessica will also kind of summarize the nature of the questions. They may or may not be attributed to individuals, but the flavor of the conversation. You'll notice in these sets of minutes, we've included all the title slides. Jessica's going to kind of collapse that into a narrative sentence or two about what the presentation is like. But the goal is really to be able to produce minutes that are just a couple of pages in length that really capture the flavor that can then be used as a springboard for somebody to understand if they want to dive into the materials and listen to the audio file. So we'll be really interested to see. The goal here again is to balance that speed and comprehensiveness with timeliness. We've had to sacrifice timeliness for far too long, and that's not my preference. I really don't want to have to bring minutes that are from last March today, but that is where we are, and we're working to correct that process while getting access to the public of the audio files much faster as that stopgap measure in January as we were working to bring you these minutes. So I'm really I look forward to being more timely and getting that additional access to the audio files out for people who want the more robust experience after the fact. And with that, I would love to take any questions now, or also if you are looking at the minutes and want to give me feedback in the interim between this meeting and the next meeting, we can also pass that on to Jessica as we work on kind of finalizing the new format as we go into this board season. So Monica, I see your hand first.
Thank you for that overview, Dave. Just to confirm, when we are making motions for the minutes, since I did not join the board until June, I should abstain from the March and April and May votes?
It's truly your preference, Monica. Many people do abstain in those instances. That's perfectly fine.
Okay, thank you. I will.
Dave, thank you. Dave, thank you for that, and I really appreciate staff's modernization of this. Like all things, information flow, everything seems to be accelerating, so I think this is a good path forward. We will have to see over the coming year if there are additional modifications that have to be made, but I think this is absolutely a step in the right direction. I don't see any other hands raised from board members, so what I'd like to do at this point is begin to achieve our work about approving all these board minutes. So bear with us as we go through this. We'll first go to the March 10th, 2022 meeting minutes. Are there comments from the board in reviewing those meeting minutes? If not, do I have a motion to approve the minutes as written? And again, I remind you, these are under tab 3.
Approve.
I believe that was Tom. Thank you. Is there a second?
Yes, Harry, I'll second.
Thank you, Harry. All those in favor say aye.
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 Are there any opposed? And abstaining? Let the record reflect that Monica's abstaining. Oh, I'm sorry, and Michaela. I thought.
And Kurt.
And Kurt. We have 3 abstentions. All right. I believe the March 10th minutes are approved as written. Let's move into the April 14th, 2022 meeting minutes. Are there comments from the board? Do I have a motion to approve the minutes as written?
So moved.
Thank you, Elliot. Is there a second? I know you're reading quickly.
Second.
Thank you, Tom. All those in, I'm sorry. I will go ahead and call for the vote. All those in favor say aye.
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 All those opposed? And all those abstaining?
Aye.
Aye.
Let the record reflect that Michaela, Kurt, and Monica have abstained. So the April 14th minutes are approved as written. Next, we'll move to the May 12th, 2022 meeting minutes. Are there comments from the board? Do I have a motion to approve the minutes as written?
Motioned.
Thank
Harry,
you,
motion.
Harry. Is there a second? Elliot?
Second.
Thank you, Elliot. All those in favor say aye.
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 Thank you. All those opposed? All those abstained?
Aye.
Thank you. Let
Aye.
the record reflect that Kurt and Monica and Michaela are abstaining. The May 12th, 2022 minutes are approved as written. We'll move to the June 9th, 2022 meeting minutes. Are there comments from the board? Hearing none, do I have a motion to approve the minutes as written?
So moved.
Thank you, Tom. Is there a second?
Second.
Thank you, Monica. All those in favor say aye.
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 Any opposed? Abstentions?
Aye.
Thank you, Kurt. Michaela, thank you. The June 9th, 2022 minutes are approved as written. You guys keeping up with these? Okay, good. Thank you, board members, for your patience. Let's keep moving. Let's move to the June 30th, 2022 meeting minutes. Are there comments from the board? Hearing none, do I have a motion to approve the minutes as written?
So moved.
Thank you, Elliot. Is there a second?
Second.
Thank you, Tom. All in favor, say aye.
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 Opposed? Abstentions?
Aye.
Okay, Kurt and Michaela are abstentions, so noted. The June 30th minutes are approved as written. Let's move to July. Are there comments from the board? Do I have a motion to approve the minutes as written? Again,
So moved.
I think that was Harry. Thank you
Yes.
for your motion to approve the July 14th, 2022 minutes. Is there a second?
Second.
Thank you, Monica. All in favor, say aye.
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 All opposed? Abstentions?
Aye.
Thank you, Michaela and Kurt. July 14th, 2022 minutes are approved as written. Let's move to the July 20th, 2022 meeting minutes. Are there comments from the board? Hearing none, do I have a motion to approve these minutes as written?
So moved.
Thank you, Elliot. Second.
Second.
Thank you, Tom. All those in favor say aye.
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 Any opposed? Any abstentions?
Aye.
Michaela and Kurt, thank you for your abstentions since you were not on the board. The July 20th, 2022 minutes are approved as written. Okay. Dave, we've completed our assignment. Thank you, board members, and we will in the future be handling that differently as Dave explained. All right, let's move into I feel like we need to all stand up and do a stretch break after that, but no, I'm joking. All right, let's,
Chair Birch,
yes.
Chair Birch. It seems to me, maybe I'm wrong, but we have new board members on here today? And
No.
I wonder if they could be introduced?
No, we don't have any new board members
Oh, I thought-
today.
Heard about that.
Both Michaela, Kurt, and Monica have been on now for a bit,
Okay.
so thank you
All right, sorry about that.
for that
Apologize.
clarification. All right, we're going to move into the February retreat follow-up. Dave's information is behind tab 4. And we always appreciate, Dave, as you are so fastidious about following up the questions that are raised in prior meetings and at the retreat. So I'll turn it over to you.
Good morning again, everyone. It's 2023 for the record. Thank you for time traveling to all of 2022. I do want to highlight that There are some questions that were asked at the last board meeting that are being prepared as presentations throughout this board season. So if there's something that you're wondering, I thought I asked this, where is this? Some components of questions from the retreat are being baked into subsequent meeting materials. But these are two pieces that I wanted to bring back and thought made the most sense and didn't really fit a broader presentation at this point. The first one is on slide 3 and was a question that I believe came up from a conversation initiated by Tom, kind of asking about how communication can flow through board members before or after a meeting. And so I wanted to turn the microphone over to our AAG, who advises the board and the agency on the Open Public Meetings Act, to share a little bit of information about this.
Excuse me, I have a board member, if you could mute yourself, I believe it's John, but could you please put yourself on mute? I'm sorry, Dave, to interrupt. Go ahead.
No worries. I'm just handing the microphone over to Michael to take care of the insights on the Open Public Meetings Act. Michael?
Okay, thank you, George. Sorry, thank you, Chair Birch. Thank you, Dave. And yeah, Michael Tunick, Assistant Attorney General, for the record. And yeah, so there was a question last meeting just regarding emailing other board members during the meeting, and we follow up with some OPMA, and so just sort of broad brushes. The Washington's Open Public Meetings Act requires that the board meetings be open to the public, such that the public may observe and participate. And then meetings is very broadly defined to be any meeting at which the board takes action. And action itself means the transaction of official business. That includes public comment, deliberations, discussions, as well as the final action of taking votes on the resolutions. Thus, basically under the right circumstances, because of the broad definition of a meeting, an exchange of email among board members could constitute a meeting subject to the Open Public Meetings Act. Now, I'll actually just skip to if a meeting is improperly held with that in violation of the Act. Each member that violates the OPMA knowingly is subject to a $500 fine for the first violation. The second and any subsequent violation, knowing violation, would be subject to a $1,000 fine. So with the that out of the way, so. For an exchange of emails to be a meeting, there has to be a quorum. And so under the bylaws, that quorum is, 4. Sorry, I just had the bylaws open. And then official business, that's just basically what you're discussing here for the board. And then and I think there was also discussion of, or concern about serial communications, and that's where sort of to avoid a quorum, one member A discusses information with member B, who passes it on to member C, and so that's also known as daisy chaining, and that's not allowed to avoid a quorum and would violate the Open Public Meetings Act. And I should say that if there is information that can't be discussed because it's more appropriate for an executive session, then that's another issue that you could request for an executive session. But if it's the board business, it should be in the open in the public. And then so it's the conditions of a quorum with the intent to transact official business, and the members communicate about issues that come before the board. That would be a meeting, and if it's done by email, it could violate the Act. And then we've also got on the slide there a link to the Attorney General's website, which has resources on open government training, including the Open Public Meetings Act, and a few just want to do, online training, that's available. And additionally, if you want in-person training, I can give you information on my colleague for that. And I see Elliot has a question. Elliot.
Yes, thank you. So what happens, let's say a member sends an email to one other board member, and then that, as you know, can go viral and cascades, but the person who sent the email has no way of knowing that, the person who sent the first email.
And so as far as and so I think there could still be a violation of the Open Public Meetings Act if, even though let's say member A does not intend for member B to pass that email along. If member B passes it along and it concerns business that comes before the board and it gets in front of enough people, you risk that it's going to violate the act. Now, as far as the individual penalties, the situation you've described in which member A was not aware that the email would go on to others, that member A probably would not have knowingly violated the act, in which member A would not be individually or personally liable for the violation.
I'm a non-voting member. Am I covered by this as well if I were to send emails to other board members?
You are still covered, yeah. Even though you won't be able to. You do have many of the same rights as the membership, as far as making motions. And so if there's what I see like consensus seeking behavior, even though you may not be able to vote, if you're you could still violate the act by seeking a consensus behind closed doors, whether it's by serially communicating with people or emailing the whole board. So it's definitely something that if it's business that comes before the board, it should be done out in the open. And if it's something that is, something that could be done in executive session, then that's a different situation. But we still would need to follow the procedures to go into the executive session to follow the OPMA. Does that answer your question, Joe?
Sort of. I guess what I'm concerned about is there was something coming up, and I sent an email up to the voting members asking their views or their thoughts on something. Would that be considered in the public domain, that email?
It sounds like you're emailing them to get their. Well, it sounds like the topic is the type of business that goes, or it's an issue that may or will go before the board, and so that is definitely getting us into some gray area.
Yeah, Michael. Michael, this is.
I don't see it happening, but for instance, if something came up with say Medicare, and here that I have a real concern about, and so I wanted to get your view on something regarding Medicare.
So,
would I best go through Dave and let Dave circulate that?
yes, Michael, let me jump in. This is Chair Birch. I think it's very critical for board members to understand that information that comes to you needs to be immediately directed to Dave. Dave and our AAG will figure out how that's sequenced into an agenda item or how that is pushed out publicly and fairly to all people. So I want to be very careful that we're really trying to clarify that there can't be this daisy chaining or spreading of information without Dave or myself and our AAG making some determinations or validations about sharing that in a more public, transparent way. Transparency is of critical importance. Dave, over to you.
Yeah, and it's important. It's not that Sue or I are trying to be a gatekeeper. We're really trying to facilitate not violating the Open Public Meetings Act, because Michael has highlighted the civil individual penalties, but the other aspect of the Open Public Meetings Act is final actions of the board could be invalidated if the discussion along the way wasn't done in the public forum or in an appropriate executive session. So that's where this definition of action is. This is where we all, put on our lawyer hats, and it can be confusing because it's not intuitive that talking about something that leads to a final vote, that the discussion itself falls under the definition of action under the Open Public Meetings Act. So it's the entirety of exactly what you just described, John. If you're wanting to engage in a discussion about how people might actually respond to something that is scheduled for vote or not, that is kind of the potential poster child, if you will, for something that is a deliberation, which counts as action, as happening outside of the public eye, which, depending on the exact matters of what the final vote is or final decision of the board is, could end up being invalidated because the process leading to that final vote violated the OPMA. So if there's something you want to share, we'll figure out the best way to do that. And so yes, always you can reach out to me or Sue to say, I want to get this before the board, or I want to have this discussion, or how do we get this information here? And we'll facilitate the way to do it without violating the OPMA.
Great, thank you very much.
Dave and Michael, this is Sue Birch. Can you clarify, there's a pithy headline, a great article in New York Times. Elliot wants to get that out. How should she best handle that?
So, Michael, I'm not sure if that was for you or for me. In that instance, I would love for Elliot to say, hey, Dave, can we get this out to the board? And we would batch together information and say, here's something for the board to share. You'll notice, board members, that we always include our AAGs on those emails because sometimes people accidentally hit reply all, and that can be the beginning of an unintended Open Public Meetings Act violation, and our AAGs will step in. This hasn't happened in a long time on the PEB board, but they'll step in and say, hey, make sure you don't hit reply all, let's stop this, and they'll warn everybody about the potential. But if you have something you want to disseminate out to the board, I'd love to be able to facilitate that for everyone, and again, make sure that we're helping people, not either purposefully or inadvertently violating the OPMA. I saw a question from Kurt.
Yes, thank you. Am I recognized?
Yes.
Okay,
Yes, go ahead,
thank you.
Kurt.
So, Michael, I just had a clarifying question. I thought I heard you say that to be considered a open meeting under the Act, there has to be a quorum. So, scenario, if I email another board member, just the two of us had a dialogue via email, that's clearly not a quorum. So would that then violate the Act?
That wouldn't violate. That wouldn't violate the Act. And one thing that we're concerned about, though, is I think we're talking about the serial communications of the daisy chain, and so there. And I think one of the questions talked about it is that, like, although maybe you're communicating with member B, what we're concerned about is that the member B then goes on and talks to member C, who talks to member D, and all of a sudden we're sort of in a gray area of, is there a quorum, or are we doing this serial communication or daisy chaining to avoid a quorum, which isn't allowed. That's not to say that you can't have a conversation with another person, but as your AAG, I want you to be careful.
And Michael, let me give another hypothetical that is maybe a little dated for our post-COVID world, but imagine that 3 board members are driving in a car together to go to a dinner, and they start talking about a conversation. And when they get to that dinner, turns out that a 4th board member is there, so some of the people are seated at the same table and some aren't. And they're like, hey, we had this interesting conversation on the way up. We were talking about X. And suddenly you're at 4 people, and then all it takes is one more serial communication by any one of those 4 members in an email, and you've suddenly had a car ride, a dinner, and an email that has created a meeting. I know we're generally not all traveling in cars to dinners right now, or haven't been for a while, but it's another illustrative example as to how conversations on similar topics can suddenly become serial communications. And it's not just an email, it can be meeting over coffee with one person, and the next person goes, oh, I wonder what the other person thinks, and goes to a 3rd board member and talks about it in email. And then you run into each other at the grocery store in Olympia, and you go, oh, I meant to ask you about this. It's just be very cognizant of serial communications is really the highlight here. And Chair Birch, I see Elliot has a question.
Elliot, go ahead.
You're on mute, Elliot. You're on mute, Elliot.
I know, it's mechanical, I'm not very good with those things. Let's say I send an email to 2 board members that we happen to have an interest in animal rights. I'm assuming, and everyone else in the board just loves cats and has 15 cats and wants to hear about it, and it goes viral. Do I have to check in with you, Dave?
My suggestion would be in that instance, if it's not something that is reasonably likely to be information related to board activity, absolutely not. I mean, you all are colleagues of each other. Some of you are friends with each other. My only tongue-in-cheek caution is one day pet insurance. If that season we're talking about pet insurance, you might want to be a little bit more careful about cats and dogs. But if pet insurance isn't on the agenda, we can all have love for furry friends.
Okay, thank you. I just wanted to know. I just wanted to make sure. I figured that, but let's get it out there.
All right, I'm not seeing any other hands. Let's continue to move forward. I think, thank you, Michael and Dave, for those clarifications. And again, ever in doubt, just get Dave looped in right away so that the determinations can be made about how to keep things transparent and flowing.
All right, that was question 1 of 2 for follow-up. My second one, under slide 5, moving forward, is about preferred provider status. And this is really a kind of a perennial question. I had hoped that John Parton would be here to share some of his insights because he has significant background in provider contracting, but he had a family emergency, so all you get is me for today, but we can continue to have conversations about this. In general, before I really start talking about the slides, remember that a provider network contract is at its basic form a contract between 2 parties. And so 2 people or 2 entities have to agree to a provider contract. Typically that's the insurance carrier and the provider. And contracting, just like any deal that anyone wants to enter into, has a host of reasons why you may or may not be willing to sign a deal. So I just wanted to highlight that at its fundamental base, it is a contract that's being signed, and there has to be mutual agreement of the parties signing that contract. And if one of them, for whatever reason, doesn't like the deal, doesn't think it gives them what they want, is overpaying, underpaying, and they don't sign, then that's the free will of contracting in contract law. So that's kind of at its base something just to highlight. So when we talk about like who decides and how does somebody become a preferred provider, it's rooted in that contractual relationship. And plans, they will create fee schedules, and those fee schedules, which really the heart of many of these provider contracts is the rate reimbursement. Those fee schedules can be driven by Medicare methodology. They're also driven by looking at different market dynamics and going, if a carrier needs to meet network access standards that are regulated by the insurance commissioner's office, there might be different regional factors that affect payment rates. And so there can be negotiations over some of those factors that might be in an individual contract. But really what's happening here is carriers are trying to produce networks that are both robust and allow access, but also have cost containment measures so that their premiums are affordable. So it's kind of that balance between access and cost. And so a lot of it is driven by wanting to meet those network access standards. And a lot of times how a provider contract is initiated, it can be initiated a host of ways. It can be the provider reaching out to the carrier saying, I'd love to be able to find out if I can be in your network because I want access to your portfolio. I want volume of your membership coming to my facility or to my provider practice. But it can also be initiated by the carrier. They're looking, again, at those network access standards and going, in this part of the state, it would be really great if we could get some more providers. And so then they're actually looking to get more providers. Or they learn that maybe they don't have a particular provider group that is desirable in the community. They might meet network access standards because they have enough providers, but they don't have the facility that certain people really want to go to. And so they may hear from membership saying, I'd sign up for your product if you had X facility in the network. And so that might prompt the carrier to go out and seek a provider contract with that individual facility. I'm going to go to slide 6 and then I'll open up for questions because slide 6 is just the last one. Now, there are a lot of different factors that go into whether somebody's going to sign that contract on either side. There are quality metrics that are created to try to incentivize payment rates. We've talked a lot about value-based purchasing at the Healthcare Authority over the last years and trying to incentivize and ensuring that we're paying for quality outcomes. There's that cost effectiveness. There's a discount that when you're a preferred provider, you are agreeing to take a set amount under the contract as your payment rate. We call that the allowed amount. And you as a provider, if you sign a contract, are saying you will write off and not balance bill for any charges that you believe you would otherwise be able to charge for the services that are being provided. So there's that balance of cost that comes into that. There's also member satisfaction survey results that might drive as to whether somebody's contract is renewed or being brought on. And again, I've highlighted a little bit about network access standards or adequacy standards with OIC. So that's just a little bit of my preliminary information, but I want to get to Elliot's question. Elliot?
I am a little confused. What is the role of HCA staff in providing providers to these different plans, giving them names, giving them leads? Is there, does HCA staff have a role in that?
That is a great question, Elliot, and I'm actually going to root my answer in the Optum Regents network dispute from this fall, or this winter, because I think it illustrates a really good point. Even with the Uniform Medical Plan, the Healthcare Authority doesn't directly work on provider negotiations and provider contracting. The agency used to before 2011, but in 2011 there was a decision that created the third-party administrator of UMP. Regions won that initial contract and they won the second procurement a couple of years ago. And one key thing that the state is purchasing as part of that service is provider contracting. So that is managed by Regents, and Kaiser manages its own network, and Premera manages its own network, and United manages its own network. They are doing those individual provider negotiations. There's not a direct role by HCA. However, we are a public entity with a very large book of commercial business. We're almost 19-20% of the commercial market between the PEB and SEB programs for the state of Washington. And so when we hear about a dispute, we definitely monitor, we get updates from the carriers on major facility negotiations that are happening, and the status of them. And if there is one that is going to termination or could result in termination notifications, we're certainly apprised. And usually what happens are both the providers and the carrier want us to know what's at the heart of the dispute. We aren't making a specific call because we're not a party directly in the contract. But for example, in the Optum and Regents dispute, we actually ended up being a mediator between the two entities. There were for lack of a better word, shuttle diplomacy calls between HCA and Optum and HCA and Regents to try to break up a logjam and figure out where miscommunications were happening. That, in my experience of the last 5 years, that was the most that HCA had been involved, but it was such a high stakes negotiation. It's rare for such a large facility to actually go to a termination notice. Shauna Lang, who is, you've heard from her before here, she's been with UMP since before, when we originally did provider contracting, pre-2011, and she couldn't remember this large of a network termination potentially going to actual termination. So, Sue and I got very involved in trying to help the parties get to finish and get to done, but that was an atypical situation. We generally don't have a direct role. That is part of the services that we're paying for as a state, is the carrier addressing and managing the network. We will raise concerns about it, and if we need to, we will facilitate conversations, but we're not a party to the contract directly at this point. Do you have a follow-up question, Elliot?
Yes, I do. My follow-up question is, so let's say an HCA staff member gets the names of 2 new providers. Do they get involved and give those names to to an insurer?
If we hear from members from PEB or SEB members, if we see in correspondence or we're in a public meeting and there's a multiple request for a certain provider group or facility to be in the network, we'll certainly pass that along to the carriers and say, we're hearing that there is a desire to have X provider group in the network. We wanted you to be aware of that. So we will pass on that is a kind of a bubbling up request from the from our membership, that we do that.
Request, do you do it?
Elliot, you cut out there. I'm not sure I caught your question.
Okay. If it's not a request, do you do it?
I'm afraid to speak in absolutes. We usually pass it on. We assume if a member is asking questions and wanting to learn about provider access, that their ultimate desire would be that the provider would be in the network. So we typically say, we're getting requests for groups, for a provider to be in the network from this area of the state. The part that I think we're less likely to do, but I can't guarantee sitting here today that it's never been done, is we usually wouldn't say, member Elliot Weinstein is interested in provider group ABC. We would typically say, we're hearing requests that ABC be in the network. But I can't guarantee that we've never passed on a member's name in those communications. Our general desire would be just to push over ABC is being requested to be in the network.
Elliot,
Okay, thank you.
Elliot, this is Sue, and one of the other things that is always happening in the background, and I was going to bring it up later, but our partners are involved in a lot of collaborative work. So the Washington Health Alliance just recently, and we will send you the link, released the Community Checkup Report, which is kind of a rating about providers. And so our clinical quality team is always kind of in the background paying attention to the strength of the service providers that we partner with in this state. And if it were to come up that there's something noticeably absent, say there's an emerging expertise of something happening, our clinicians are at these, their quality measurement team meetings. These things go on monthly. So there's a lot of this work alongside Bree Collaborative and many of their work committees. So there's other ways that we kind of monitor provider quality. But as Dave says, we pay our intermediaries to do the network. It's the hallmark of what Washington has done. And so there are other ways we influence informally, but that is not really in our direct role and responsibility. Michaela, I see your hand is up.
I think there might have been someone
I'm sorry.
online.
Tom, I'm sorry, you're next. Go ahead, Tom, and then Michaela, you'll be next.
Okay, I have two slightly unrelated questions. One is on the method of becoming a preferred provider. I know someone personally who was a preferred provider, and when she became pregnant, she had to cut back a large number of her clients, and that happened to be right at the time that the HCA turned the network over to Regents to manufacture or to anyway, turned it over to Regents. So she then, after about a year later, she applied to become again a preferred provider, and she was turned down. And she was turned down 3 times and then gave up. And so I'm curious. There was no other quality metric that she didn't meet that she had before, and she was never given a reason as to why she was denied becoming a preferred provider. And that's kind of led to a lot of my concerns about how you become a preferred provider, because it seems like she would have met every qualification. She never got to the point where she could say, I'm not going to accept that amount of reimbursement, for example. She was just flat out denied. And so that's I'm curious about how that process could end up in that situation.
So Tom, the answer to that, there's a variety of reasons. That's why I started my insights about it's a contractual relationship, and there can be a host of reasons why someone may not, either side, both. I mean, I'm aware many times where a carrier will proactively reach out to a provider group, and it just falls on deaf ears on that side of the equation. So there can be a host of reasons why. An example that I could come up with, but I don't know if it applied in this scenario, but it's a scenario that I'm aware of that can happen, is there is a desire to have some people in a network that have an allowed amount to the exclusion of other providers in the community, so that you are driving volume to specific parts of your network. It's very rare for even a PPO to have every single provider who wants to be in network. There's a desire to have your funneling and giving discounts to drive volume to certain provider groups. And so, or within your network, and you're trying to keep things within a closed network. There's so much variability that can happen in payment processes that driving towards that uniformity and the fact of having a network has people who aren't in the network. And so sometimes there's this, we have enough of this provider, and I don't know if this is the case in that scenario, but it's an example of why a carrier may say, I'm not going to add more of X providers. I already have the volume of preferred providers in network to meet the demand that I see that I'm serving in this population, and adding more network providers doesn't increase the network adequacy that I've already achieved. So it could be something like that.
Go ahead, Michaela. Michaela, go ahead. You were next.
Yeah, thank you. So this is slightly related, but just kind of got me thinking, when I'm looking at these multiple factors, what I don't see and wondering, maybe it's in here, but is there any way that we can kind of leverage our influence as one of the largest contractors of the kind of two healthcare providers to try, or insurance providers, to try and figure out if we can incentivize them to find ways to increase kind of the diversity of the preferred providers in certain regional areas to better match kind of the community, and specifically thinking around mental health support?
Michaela, what a great question, and I'll start and Dave can tag on. If you peruse, and we will send you the website, the community checkup report, in fact, they are now overlaying the vulnerability indexes that are really driving towards what is the capacity of these certain providers to deliver on the populations that are uniquely in those areas. So we're starting to see our intermediaries, our TPAs, regions, and others, starting to really bring in these equity, kind of diversity, inclusion. This is a long journey, though, because we have decades of ignoring this issue and under kind of valuing that diversity, equity, and inclusion work, and it is just beginning to really take off. So the answer is kind of yes and no. It's in motion, but it is going to be a long journey of building more DEI competency in our provider networks. Great question. Any other questions from the board? Tom, I see your hand is up. Go ahead.
Yeah, I have one more question. So, about 2 years ago, we were having discussions about whether to increase the amount of visitations you get for alternative medicine. And one of the factors that was brought up in our conversation was that people were not using those as much as you would think. And I believe that, for example, for LMPs, I believe it was 10% of our subscribers were I think LMPs were the largest. It might have been around 20%, and acupuncturists were 10%. I can't remember the exact percentage, but it was low. The point is that how do we have, sorry, I'm babbling here. What I'm curious is part of the reason for the utilization, is it because people are having trouble finding those that are preferred providers? If that is the case, then that might explain why those low numbers to begin with. And having talked to a number of people who have attempted to become preferred providers, it seems like it's a very cumbersome process to begin with. And then if you're the subscriber and you're trying to deal with finding people and there aren't a lot to begin with, you might just give up.
Tom, thank you for that comment. There's a lot to unpack there. And I want to clarify, you kind of broke up. I think you said LMP. Is that correct?
Massage therapy. Yeah, licensed massage practitioner.
Thank you. I just wanted to make sure for the public, we're talking about the licensed massage practitioners. So There's, as I said, thank you for that comment. I think, Dave, I think we should direct staff to bring this back as a future issue as we continue to explore this, because
I'd love John to be here too.
we really need John Parton and a few others to be part of that conversation. So, Tom, thank you. I don't really have much more response to that right now, and we'll need some of our experts as we dig deeper into kind of a more fact-based response to that. All right, I want to keep moving us along. Dave, were there any other follow-up items? So Dave, thank you for taking us through the February retreat follow-up. I'd like to now move us into our next agenda item, the bylaws amendment. Dave is again going to bring forward this information that he presented last time, and he's going to have us vote on some amendments to the PEB board bylaws to clarify our practices regarding public comment. After Dave reviews the amendments with us, I'll ask for a motion to adopt and a second, and then we'll invite public comment on the amendments, and I will ask for discussion from the board until we are ready for a vote. And Dave's materials are behind tab 5, so Dave, please take us back to this issue that you've presented on before.
Good morning again. I think this is my last presentation, then I get to turn it over to my staff for the rest of the meeting. So last month I brought a bylaws amendment. We'll go ahead and go to slide 2. And this was really initiated, and I want to give credit to board member Elliot Weinstein for bringing this to my attention in between board seasons. This is really just memorializing the standard practice that everyone that has been involved with the PEB program believes has been the standard practice for a long time, but just it wasn't written this way in the bylaws. And it's really just clarifying that point that I made at the beginning of the board meeting, especially for new members of the public who are attending, that there's general public comment at the end of the meeting, but when there's something scheduled for action, like this very bylaw amendment, during the motion practice, there will be an opportunity for the public to comment on that specific subject matter before action is taken by the board. And so this is really memorializing that and continuing to give discretion to the chair for other opportunities that may come up as needed throughout the meeting. But it kind of, again, reinforces and puts in writing that there will be an opportunity for public comment. The chair will always call for public comment during the voting resolution motion practice before a vote is taken on that specific matter. So you see on slide 2, the strike, the format here is read as new words, strike through would be removed words. This is the specific proposal. On slide 3, just a reminder about the bylaw amendment process. Unlike most votes of the board, most votes are a simple majority, which means most of the time 4 votes are needed. In this instance, the bylaws themselves dictate that to amend the bylaws is a 2/3 vote, which you have to round up when you do 2/3 of 7 voting members. That means 5 of you have to vote to affirmatively change the bylaws. The last thing I'll highlight, which isn't on the slide, is that I took the same thing to the SEB board, and the SEB board last week passed this change to their bylaws, so they have mirrored this practice as well. So I'll move us to slide 4, which is just the clean copy of the final version if you were to pass it, and I will hand it back over to the chair for next steps.
Great, thank you, Dave. So at this point, I'd like to take a vote on the PEB board bylaws amendment. So let me just officially read this into the record. The Public Employees Benefits Board Bylaws, Article 5, Meeting Procedures. The board votes to amend the public testimony section to read as follows. The board actively seeks input from the public at large, from enrollees served by the PEB program, and from other interested parties. Time is reserved for public testimony at each regular meeting, generally at the end of the agenda. Opportunity for public testimony at board meetings shall also be made available immediately before the board's vote on a resolution. At the direction of the chair, opportunities for public testimony may also be made available at other times during board meetings. The chair has authority to limit the time for public testimony, including the time allotted to each speaker, depending on the time available and the number of persons wishing to speak. Is there a motion to adopt?
So moved.
Thank you, Elliot. Is there a second?
Second?
Michaela, thank you for that second. Now, are there any comments from the audience? We are observing for raised hands. Yes, we have a raised hand, and I will ask staff to open up their ability to speak, and they will identify themselves and... Okay, Amy, we are going to open up your line, please, and if you'll recognize yourself and your affiliation, and then have a couple minutes for your comments. Go ahead.
Thank you, Chair Birch and members of the board. My name is Amy Fortier. I'm in Swim, Washington. This revision in the bylaws, I think, will be most useful, not only as a benefit to the board for information and feedback for prior dialogue, informed action, and then also for both enrollees in the program and other interested parties, because being able to have this comment time when the either subject matter expert or the presenter is there and available to address any issues, concerns, questions, or additional information should benefit us all, and I commend the board for revising these bylaws. Thank you.
Thank you for those comments, Amy.
Fred Yancey.
Our next commenter from the public is Fred Yancey. Fred, welcome back, and we see you. Can you go ahead and introduce yourself? And I think your mic is open.
Good morning, Chair Birch and members of the committee. Fred Yancey, Washington School Retirees Association. Like the previous speaker, I'd like to commend the board and in particular draw attention to, I believe, and I won't put words in her mouth, but I believe she was speaking about the addition to the phrase that it says at the direction of the chair, opportunities for public testimony may also be made available at other times during the board meeting. I think that's an important addition because many times I have to take notes throughout the meeting and then have to kind of summarize a whole bunch of different topics that are covered at the end, and often the expert or presenter is not available. So I think that opportunity ought to be exploited more, in my opinion. But thank you very much for considering this change.
Thank you, Fred, for those very positive comments, and I will certainly pass those accolades on to the full PERB team, as well as, again, our thanks go to Elliot. I see another hand raised, and I can't read their name. Aruna, go ahead. We're opening your mic. Please identify yourself and your affiliation, and we'd love to hear your comments.
My name is Aruna Bhuta. I'm from Spokane, Washington. I'm a retired social worker from Children's Administration. I also am very much in support of a chance for public to give input about the issues before the action is taken, vote is taken on an action matter, so that you have one of the important stakeholder also to be, the consumer giving the input on the decisions that you are making. And I really like the previous person's comment, Fred's comment about, being able to ask question if need be, during the discussion when the subject matter expert is present. And also it will be helpful if the consumers know as to when the decisions are going to be made or when the changes are going to be made ahead of time so that they can be attending the meeting and giving the feedback. Once again, thank you for taking this proactive action. Appreciate it.
Aruna, thank you for your comments. I just want to remind members of the public, as Dave presented early on, the board always have a 2-cycle process. So we don't take action on anything that hasn't already been kind of teed up in previous meetings, but it is incumbent upon the public and the associations to monitor the activity of the board, because we just, quite frankly, have so much that comes before us. And I just want to thank all of our commenters too. We have to run meetings succinctly and orderly, and so there's a lot of work that needs to be done and contained. So we will according to the chair's prerogative, just need to keep moving things through. Dave, I see you want to make a comment.
Two things. We always include presenters' emails at the end of the slide deck. So if there's an opportunity, you can write to the staff, like here, we're showing the question slide for me. You can drop me an email in real time. I won't obviously respond in real time, but if you want to capture your question, we include the presenter's information for contacting them after the meeting. Or like I said, you can in real time provide that. Because sometimes, as Chair Birch is saying, we're a little bit behind in this agenda itself, so we may not be able to open up for questions on every presentation, but that's one opportunity. The second thing I just thought I'd highlight is we send out our board materials the Monday before the board meeting in a Gov Delivery listserv. We have 74,000 members of the public for the PEB program who receive that information in advance of the meeting, and we've been pushing out more information to people to make sure they understand how they can sign up for that listserv. But I thought it would be helpful for the board to know that 74,000 people in this, well, I guess they're not all just in the state, but 74,000 people receive the board materials that you are reviewing in this board meeting in advance of the meeting.
Thank you for that clarification. Are there any other members from the public? No, I don't see any. I'd like to move us now for any comments from the board. Not seeing any. Again, Elliot, we thank you for moving this issue forward. I'd like to do a roll call vote at this point to codify this bylaw amendment change. I will call on first Tom McRobert.
I vote yes.
Thank you. Harry Bossi.
Yes.
Michaela Dolman.
Yes.
Elliot Weinstein.
Yes.
Monica McElmore.
Yes.
Kurt Spiegel.
Yes.
And I'm Sue Birch. I vote affirmatively as well. The PEB board bylaws amendment passes. Thank you all very much. I would like to just call for a quick, unexpected, unplanned 5-minute stand or bathroom break for those of us that have had too much coffee. So members of the public, we will be back to you in just at 10:20, 5 minutes. Thank you. Board members, we're going to go ahead and resume. Thank you for that little standing break, bio break. At this point, I'd like to get us going again on our next topic. The agenda item that we're going to move into is our legislative update. Cade Walker is our Policy Rules and Compliance Section Manager in our ERB division, and he's going to provide us an update on what's happening with bills in the 2023 legislative session. Cade's materials are behind tab 6. Cade, over to you, and lovely bow tie.
Thank you, Chair Birch. And good morning to you and the rest of the board members and those who are listening this morning. I'm Cade Walker. I'm going to provide you another thrilling update of the current legislative session that we have underway. Next slide, please. You can see here just a couple of the numbers about how much work we've been doing in the Employee Retiree Benefits Division. I want to just note that we've had a significant number of fiscal notes this year, which is maybe not unusual given that it's a long session and setting the budget for the year. So we have had a pretty significant number of fiscal notes that have come through, which just shows the importance of our fiscal team working to get the numbers prepared and sent back up to the legislature for them to continue the tasks they have on their hands. So I usually like to take this time to acknowledge all of the hard work that our analysts do and our fiscal team does during the session. This is additional responsibilities that they each have during the year to basically stop whatever they're doing when a bill analysis assignment comes through and get working on that to make sure that we're providing good and timely feedback to the agency's leadership and to the legislature. So great job to our team for the continued work. Next slide, please. Here's our funnel of how a bill becomes law. This is just tracking the bills that we have designated as high priority lead responsibilities for the ERB division. This is a little out of date because we have had a cutoff that was yesterday. As probably a lot of you know, but many of you may not, that the legislative cutoff yesterday was that any piece of legislation that did not get voted off the floor of the originating chamber, meaning either the House or the Senate, and then moved on to the other chamber, is considered dead for the remainder of this session. We did have a number of bills that didn't make it past the originating chamber, but a lot of bills that did make it past. So we will continue to be very active the remainder of session as we watch legislation move through the process. Next slide, please. So moving into the bills, I think what I'll do, because I did go over almost all of these in the last meeting, is just to call out which bills are still moving and which bills have not made it past, did not make it past the cutoff, either the cutoff from yesterday or a cutoff that was a little over a week ago. Our agency legislation, Senate Bill 5700, again, this is just legislation that is cleaning up a lot of our PEB and SEB statutes. It remains active. It has made it out of the Senate and is now over in the House for considerations. And also our legislation that we had worked with the legislature to draft, Senate Bill 5421, regarding the Public Records Act exemptions for PEB and SEB information that's collected for enrollment purposes. That too has also been, has passed and is moving on in the House at this House currently. Next slide, please. Senate Bill 5275 regarding the ability for certain employer group types, specifically Indian tribal schools, the associations representing school employees and school board members to participate on a voluntary basis in the SEB program, which is very similar and modeled after the current program that exists, or the current ability in the PEB program for municipalities, which typically are cities and county governments, different types of municipalities and districts like water districts, fire districts, sewer districts, to be able to participate in the PEB program, creating a very similar program to the of that in the SEB program for the defined employer group. So that continues on. Then we have on the retiree front, House Bill 1008 regarding expanding the definition of separated employee to include Plan 2 members, is continuing to move through on the Senate side. Senate Bill 5490 regarding deferred retiree coverage and a small second bite at the apple for a small population of retirees continues on, as well as both the House Bill 1804 and Senate Bill 5696. Now they are not, they are companion bills at the start, but they currently have been amended differently, with House Bill 1804 having a little bit of a different language in there regarding some payments for retirees from political subdivisions or employer groups that participate in PEB. This is really, it's a lot of legislation that has a fairly small effect. This is just regarding employer groups and the ability for their retirees to remain in the PEB retiree coverage they're in if their employer group decides to leave the PEB program. So we're continuing to track that very closely. Not that it has a substantial impact for the entirety of the PEB population, but it will have a very positive impact for certain groups of individuals who have lost coverage due to their employer group leaving the PEB program and allowing them for that. So it has a lot of administrative work for us, but not much. You know, it will have a lot of positive impact for a small group, but not necessarily for a very broad group. Next slide, please. On the medical cost sharing, let's see, I'm making sure I've got all my up-to-date notes here. 5242 continues moving through, 1151, 1222, and 5396. So all of these under the four bullets have at least one of their bills is continuing to move through the session. 1261 did not make it past the House floor cutoff yesterday, but 5396 did. So all of these pieces of legislation that seek to reduce or eliminate some aspects of the member cost sharing or are continuing to move through this session. Next slide, please. let's see, 5213, that did actually not make it past the cutoff yesterday in the Senate, so the legislation that would have regulatory impacts on pharmacy benefit managers like MODA, who does the pharmacy benefit managing for the UMP portfolio, that legislation is not moving forward this session. As is 1269, that also did not make it off the House floor yesterday, so the amendments to the Prescription Drug Affordability Board has also stalled for this current session. And but 5729, the continuation of the $35 a month cap on insulin has continued to move forward and is now at the House for its consideration. Next slide, please. Again, just going over, I don't have the specific details on which one of the new or expanded licensures. I think the majority of these are moving forward. Some of them may have not, but once we get to the end of session, I'll make sure to provide a wrap-up of which of the new or expanded licensure bills made it through this session, and we'll continue to track that otherwise. Pet insurance, while 1208 sadly did not continue forward, the Senate bill version 5319 does continue to move forward, so we may see that pass through the House, and if so, it's likely to get signed, and we'll see some regulatory impacts on, or we'll see some regulation on pet insurance in the state market, which if we see that start to happen, I'm sure we'll be bringing that to board for their awareness and consideration for offering pet insurance. Now that is something that is permissible in the SEB program, but we are confident that if the SEB program is interested in taking that up, that we may bring that to the PEB board for consideration and seeing about expanding the types of voluntary employee benefits that can be offered under the PEB program, similar to the SEB program. 1357, modernizing prior authorizations. This bill has had a lot of work that's been done by the agency. Our clinical care and care transformation team has been doing a fantastic job tracking that in the legislature's attempt to modernize and create a new system or a enhanced system for prior authorizations for medical services and pharmacy prescription fills. Last, 5241, actually it should be 5420, oh wait, no, that's not true. It is 5241, my slide had a little different. So 5241 did not make it past the Senate floor yesterday. This is doing some regulatory, would have had regulatory impacts on the health benefits exchange and looking at other criteria that the attorney generals would have in regulating consolidations in the healthcare world. But it did not pass, so we will continue to monitor it because it may be something that comes back up next session. But for this session, it is currently no longer moving forward in the process. With that, that's the end of I was trying to make sure I move through quickly and maybe make up some time for us. I did want to see if Dave had anything he wanted to add, or also see if Dave wanted to talk at all about any of the process that we go through in the agency of testifying on legislation and whether we sign in on legislation as for or against or as other. See if he has any comments he'd like to make about that.
Thank you, Cade. Dave, over to you, and then I see we have a member of the board that wants to speak.
I think I think Cade did a great job. I would rather just start with Tom's question.
Go ahead, Tom.
Yeah, I'm just curious, Kate, if you could explain what modernizing prior authorizations means exactly.
Oh, that is a great question. There's a lot of components to that legislation. It is requiring the Office of the Insurance Commissioner to set up new protocols for insurance carriers to comply with regarding prior authorization requirements they have in their policies. Some of those requirements, and I can get a more exhaustive list at an updated meeting. We have a lot of information on this legislation. It's had a lot of drafts, but it has certain requirements placed on the ability of plans to not deny prior authorizations that are almost always approved. So if there's a service or a medication that requires prior auth, but it has something like, I think, like a 90% approval rate or a 95% approval rate, that it has some different requirements that are imposed on it. And so it's trying to take it's a very broad bill regarding prior authorization, even though that's fairly niche in the insurance world. We know how much of an impact it has on individuals. So, and I think the legislature is obviously very aware of that as well, and trying to create more streamlined processes, taking a look at how the prior authorizations have been handled, and the frequency of approvals or denials in certain services, and using that as an indicator of how the carrier should be managing those moving forward. So that's a bit about what I know off the top of my head with that. To get further into that, I need to go and speak with our analysts and bring some information back for you if you'd like.
All right, that'd be great. Thank you.
Thank you.
I think Elliot has a question too.
Yes, thanks for bringing that up, Tom. Kay, does this apply to PEB plans as well?
It does. It is, I think the current, there's been some back and forth on it, or some changes. I believe the current version does apply to the entire PEB book of business, but I want to just see, Dave, do you have any other information on that? I think it applies to everyone, but I know that an earlier version didn't, but we are where we're at now.
Yeah, I agree, Kate. There's been a variety of versions. I think the current version is it applies to PEB, except for the part of PEB that it can't apply to, which is Medicare pieces, because that's preempted by federal law. So I'm pretty confident that that's its current state, but as we get to subsequent presentations where the number of bills is really smaller, Kate will go into more detail. We'll start removing the strike-throughs that, just for historical purposes don't need to be there, and Kate will spend a little bit more time on the details of the ones that are nearing the finish line. And as Kate said, there have been multiple iterations of those bills, and some of them have included PEB and some of them haven't, but I think the exact version right now does include PEB, but there's an acknowledgement that it can't impact Medicare plans because of the, I think there's a preemption piece on that, so.
Thank you, Dave.
Other questions from board members? All right, Kate, thank you. We'll let you go back to the legislature and all this monitoring, and I know you'll be back at us at next board meeting. Now I'd like to move us on to our next agenda item, the PEB program financial insights. Molly Christie, who is our ERB fiscal information and data analyst, will share the information regarding the financial aspects of the PEB program. Her materials are behind tab 7. Molly, welcome.
Thank you, Chair Birch, and members of the board. I am Molly Christie for the record. I work on our ERB finance unit. And I just want, I will mention, so we have one fewer thing to bring back next time. I am the analyst on the fiscal note for 1357. I can confirm that it does apply to UMP. There's a specific section where it applies to UMP, and then another section where it applies to our fully insured carriers. And the most recent version, because it is a big bill and there have been a lot of versions, essentially creates some new time frames, a condensed time frame for prior authorizations. It's very much more condensed for UMP because right now, since UMP is self-insured, we only have to follow the federal timelines as opposed to the state timelines that are regulated by the Office of the Insurance Commissioner. It has a little bit less of an impact on our fully insured carriers because it's not a huge change in those prior authorization timelines. And then there are some requirements around creating an electronic prior authorization process, which would make it easier for providers to submit those prior authorizations and to understand the process with each carrier that they're working with. So those are some of the big pieces, but I'm happy to talk with anyone, or you can email me if you have specific questions about that bill. So I will, today I'll be presenting on some financial insights for the PEB program. And I wanted to bring this today. We wanted to talk about some of these other topic areas that we cover on our finance team. This is like the other side of the work that we do beyond just bringing you rates each year. And I shouldn't say just, because there's a lot of work that goes into bringing you those rates. And Sarah will kind of mention this too when she talks about hearing aids, but a significant portion of our work involves monitoring and analyzing cost and utilization trends to support the program management and also all of the decisions that we bring to this board and decisions that are made internally and externally with all of our stakeholders. This first slide, we want to start off by giving you a sense of how costly it is to cover a family with children in PEB versus a benchmark. So where are we kind of falling in terms of our total annual medical cost for our non-Medicare population? This includes what a family spends on healthcare, in other words, their monthly premiums and out-of-pocket costs, as well as what the plan pays. And then we've taken a high-level look at total annual medical cost for this is specifically for a Tier 4 family. So that is a subscriber, a spouse, or state registered domestic partner, and then children, and compared it to a national average that's developed by Milliman. It's called the Milliman Medical Index, and they create this average family score, and they say, how much does this average family of 4 cost per year for medical coverage? And we have a few takeaways from this data. Firstly, you'll notice that total medical cost is increasing. Between 2022 and 2023, it's about 12% growth. So it does look a little more dramatic for those years than if you look back at previous years. And this is higher. We talked about this a little bit last year. Tanya discussed it a little bit last year when we presented rates. But really what's happening is that we're catching up a little bit from artificially low spending during the pandemic. And that wasn't fully captured in 2021 or 2022 rates because we do a 2-year look back. So the experience that we're using to set rates and project trends is a little bit dated. So that's why we're seeing a bigger jump for 2023. And also on a national scale, the healthcare sector is still experiencing some uncertainty post-COVID, and that might drive some continued volatility. But this isn't something that is entirely unexpected or outside of general trends that we're seeing. Secondly, the average Tier 4 family on UMP Classic is less costly than the average family of 4, that figure that's developed by Milliman based on national data. So in 2022, the average UMP Tier 4 family cost about $26,400, that's a rounded value, but that's total medical cost, whereas the national average family of 4 cost about $30,000, or just over $30,000. This could be due to several factors. So there are a lot of things that go into this. We could look at, population characteristics. How is our population different from a national average? How much does healthcare cost in our state? What is our PEB-specific procurement strategy, and how does that affect it? Because we tend to be, we tend to be very aggressive in making sure that we're getting the best rates for our members. But the one thing that this doesn't mean, and I think it can be confusing when you hear that number, is we are not covering less of the cost of healthcare in UMP. What this means is that our members just cost less overall. And we'll move on to the next slide. We are seeing a similar trend on the Medicare side. So this is specifically average total annual medical and pharmacy costs for a subscriber and spouse or state registered domestic partner enrolled in UMP Classic Medicare. So I just want to point out on the previous slide, we were looking at a family on Tier 4. This is a family on Tier 2, because typically the families that we see, the accounts that we see on our Medicare side are a subscriber and spouse, and they don't typically involve or include coverage of dependents, child dependents, although sometimes they do. And overall, you see this increasing trend again in costs with 2 significant spikes, one in 2018 and then another in 2023. And we've actually, in previous presentations, we kind of covered that 2018 jump. That's when we saw a large increase, and it drove this proviso from the legislature to analyze options for our Medicare portfolio. And we've talked extensively as well about what's driving this trend, and it continues to be pharmacy spending. That is the primary driver of our Medicare costs in UMP Classic. You'll also notice if you look at the actual numbers of costs, that it is higher to cover 2 people in Medicare than it is to cover a family in non-Medicare. This is something that we would expect because of the characteristics of those 2 populations. Things like age, health status, utilization, all play a part in how much it costs to cover someone per year. The next slide shows the average monthly spending breakdown. So we're moving from annual to monthly for a Tier 4 family on UMP Classic. And this includes the employer contribution, so that's the state index rate in light blue. We have the employee monthly premium in green, and then we have the employee out-of-pocket cost per month in dark blue. The out-of-pocket cost, that's what you would think of as co-insurance, co-pays, deductible, what you're actually paying if you get a bill from the doctor. And right off the bat, you'll see that the employer contribution is approximately 74% of total monthly medical cost. And I want to point out that you may be thinking, wait, it should be 85%. We have this 85-15 split, and we do when you just consider the bid rate, and the bid rate does not include this member monthly out-of-pocket cost. It doesn't include co-insurance, co-pay, deductible. So if you were just to look at the bid rate, you would see that the employee is paying 15% as their premiums, and the employer is paying 85%. When we build in this out-of-pocket component, then we see that the employer as a whole for total costs is contributing about 74%, and then the remainder is covered by the employee as out-of-pocket cost and premium. And when we compare this breakdown to the national average for a family of 4, again looking at the Milliman Medical Index, we find that Washington contributes significantly more toward employee health insurance than the average employer-sponsored plan. So we're at about 74%. The average employer-sponsored plan for a family covers about 58%.
Molly?
Yeah.
This is Chair Birch. Can I just ask for a point of clarification? Our slide says total medical benefits, and you said health. Is this inclusive of vision and dental for our employees, or just medical?
So this is inclusive of medical, pharmacy, and vision, because vision is currently included in our medical benefit in PEB. However, it is not inclusive of dental.
Thank you for that clarification.
So moving on to the next slide, I created a similar graphic for our UMP Medicare plan, UMP Classic Medicare. This shows the average monthly spending breakdown for a single retiree subscriber. So we're not talking about a family here, we're talking about a single subscriber in UMP Classic Medicare. And here the state contribution, which is the Medicare subsidy, is in light blue. The retiree monthly premium is in green again. The retiree out-of-pocket spending is that really small sliver in dark blue. And then the biggest portion here in gray are the Medicare coordination of benefits payments. So as a reminder that those COB payments happen when Medicare pays primary for a Medicare covered service under Parts A and B. Any remaining medical costs that are not covered by original Medicare are typically covered by UMP, and so we see that members pay little to nothing out of pocket for medical services. That's why that gray portion is so big and that little blue portion is so small. That dark blue portion, it's about $25 that we're estimating for the average subscriber, reflects pharmacy spending. So what you're gonna pay in co-insurance or co-pay for your prescription drugs each month. These are fully paid for by the plan and the retiree, meaning that CMS, Medicare, does not contribute any money. They don't subsidize the pharmacy benefit for our UMP plan because we have creditable drug coverage. We do not have Part D drug coverage. And again, prescription drugs account for more than 60% of our premium. That's what's really driving our premium, because Medicare covers such a large portion of our medical costs that doesn't typically contribute a lot of growth toward our monthly premiums. And then in general, one last point here, if we're comparing retirees to employees, which we don't typically do, again, because these are very different populations, but if we were to compare, retirees in UMP Classic spend less out of pocket each month, at $25, they're not typically spending a lot, but they do spend more on premiums relative to our employees. Next slide. We also looked at the specific cost drivers behind total medical spending in UMP Classic. This slide reflects the non-Medicare population, and I'll walk through the different categories so you understand what is included in those. Inpatient in blue includes hospital stays typically. So those are inpatient hospital stays, inpatient surgeries, that type of thing. Outpatient includes things like outpatient surgery, ER visits, and associated labs and testing. Professional in green are your doctor's visits. So those are doctor's visits for primary care, specialty care, in-office behavioral health, telehealth would all be included in professional. And then other medical services in purple covers things like ambulance, durable medical equipment, including hearing aids, and certain types of drugs. Most drugs, however, are covered under the pharmacy benefit, which is in orange. And there are two significant trends that present themselves in this slide. First, inpatient spending, which is in blue on the left-hand side. If you watch the bars, they're slowly getting a little bit smaller as we creep through time up to 2022. So inpatient spend has been decreasing, but right next to it in light green, we see that outpatient spend is increasing a little bit. And this started before, we can see that it started before 2020. So there is some impact of the pandemic on the pace of this trend, but it is a trend that kind of predated a lot of the volatility that we're seeing, and some of it, I don't know if I want to say a lot of it, but some of it is due to a push to move certain elective surgeries and other services to an outpatient setting if they don't need to be performed at a hospital. And then the second big trend we see is pharmacy. Pharmacy is just always on an upward trajectory. We are likely to just continue to see pharmacy costs increase as a proportion of total costs. Next slide. This is the Medicare cost drivers. So you see some topics here, but I'm going to walk through a few of these. The biggest difference you're going to see is that pharmacy is a much larger portion of overall spend because on the medical side, we're receiving those COB payments. So the plan is not having to pay a lot of medical claims because Medicare pays for those claims as primary. You'll also notice that pharmacy spending in 2020 took a pretty big jump. So we go from 60.8% in 2019 to 64.4% in 2020. And that's really just because we saw a contraction of medical services. And so pharmacy did not see an impact from COVID. So it looks like it's a larger proportion of total spending in that year. But then when we go to 2021, those other service categories return to kind of the expected proportion. They revert back, and so it normalizes a little bit. We're going to be monitoring the inpatient paid claims for 2022, and I should note on these slides, when I say 2022, that's run out through, it includes paid claims for the first half of 2022, so through June. It's not a full year, so we need to continue to monitor those trends. We will have the full year data. We should have it soon here, but it takes some time for all of those things to get paid for us to know exactly what happened for the full year. So in 2022, you see this jump for inpatient in blue from 4.1% to 6.1%. But some of our more recent data is showing that 6.1% really isn't that high. That was just through the first half of the year. So we'll keep an eye on that, but it's probably still following that downward trend in reality. And then the other area I want to point out that you'll see in purple is in 2020, we had 10.2% of costs attributed to other medical, and then in 2021, that jumped up to 15%. That is probably largely due to a change in the coverage for hearing aids, and Sarah's going to talk about this in depth, so I'm going to let her cover that in the next presentation. But we do see this in several areas when we're looking at our trends. Next slide. Digging down a little deeper, there are select services that had some notable trends. This chart shows trends in per member per month spending in UMP Classic non-Medicare. We have behavioral health, inpatient maternity, and inpatient surgery for 2017 through the first half of 2022. The size of the bars does represent the portion of overall spend. So inpatient surgery is a larger portion of our spend than inpatient maternity, which is kind of a subset. We saw with behavioral health that the trend has been increasing since 2017, but did see a significant bump between 2020 and 2021. And this is really tracking with international trend in behavioral health. According to the World Health Organization, in 2020, the prevalence of depression and anxiety increased 25% globally. And that was mostly impacting, or the most impacted groups were young people and women. So this is an area that as an agency we monitor really closely, but as a program we'll also be looking at this. In the middle here, we have inpatient maternity, which saw an increase during this period, but most significantly in 2021. And then we do see it also staying high in the first half of 2022. It's, a lot of what we do when we see these trends, these real trends, is we hypothesize why is this happening. I think, you could look at this and say, well, you had the pandemic, but then you had vaccines, and you have people who have more opportunities for remote work, which provides some flexibility. A lot of this comes down to family planning and personal decisions around starting a family. Changes in the economy might impact those decisions. So that's probably why we're seeing that bump between 2020 and 2021. And then, as I mentioned on the last slide, inpatient surgery has been decreasing, and we saw a really big decrease in 2020 due to COVID, and that trend just has not recovered. Next slide. This is the Medicare notable service trends, and we don't see quite the same picture. Overall, behavioral health on the left is a smaller portion of spending than non-Medicare, and it hasn't experienced the same kind of the same upward trend that the non-Medicare population has. I would say that this might be due to demographics, or at least partially due to demographics, as older age groups are less inclined typically to seek behavioral health services. We did observe, we dug a little bit deeper, and we did observe that inpatient behavioral health increased between 2021 and the data we have so far for 2022. But at the same time, we saw outpatient and professional decrease, so it kind of, it ended up being a wash, and we saw the claims kind of go down so far for 2022. Moving to the middle of the chart, hearing aids saw a very dramatic increase in 2021. Again, Sarah's going to cover this topic today in much greater detail. But briefly, this is due to a change in the coverage levels for hearing aids that started in 2021. It was based on legislation passed in the 2017-2018 session, and coverage went from $800 per 3 years to an unlimited benefit per 5 years. But when it was implemented in 2021, it reset the clock for everyone. So everyone was eligible to receive new hearing aids starting in 2021. And then inpatient surgery, again, I've mentioned this already, it's following that same downward trend, but then we see it spike up in 2022, the first half, but that is probably not going to hold as we look at the claims run out for the rest of the year. Next slide. We also examined the risk profile for the PEB non-Medicare population. We broke it down by members enrolled in UMP and non-UMP plans. And then SEP is included on here because we're presenting this slide to the SEP board as well, and it's helpful for them to have PEB as a benchmark because they still have, they don't have a lot of that historical data, so we've been including PEB as a benchmark in a lot of the data that we bring to them. Medicare is not included because we do not calculate risk scores for our Medicare plans. So this is just non-Medicare. For context, risk score is a measure of how healthy or unhealthy a population is and how that is expected to affect the benefits costs of the group. So a higher risk group is costlier, a lower risk group is less costly. And risk score is developed by assigning a score to each enrollee based on a lot of variables. We look at their age, their gender, their medical and pharmacy history, their diagnoses for a specified period of time. And these scores are compared to a 1.0 risk score, which is average. It means 1.0 means average health. And on this chart, the average 1.0 risk is based on national data. A risk score above 1.0 is higher than average risk, and a risk score below 1.0 is lower than average risk. So orienting to this chart, the average risk cutoff of 1.0 is between the light green and the dark green segments, as pointed out with the arrow. Blue represents people who are assigned a low risk score. Light green is people who are below average risk. Green or dark green is above average risk. Purple is high risk. And orange is very high risk or extremely high risk. We can draw a few insights. Firstly, there are more people below average risk than above average risk across all groups. And this is exactly what you want to see with insurance. This is why insurance works. When people are healthy, they help subsidize people who are less healthy. And this keeps care accessible to and affordable for everyone in the group. So at any time, anyone can use health care, but at any time, most people are healthy and some people need to use health care. We also see that the PEB program has an overall higher risk. They have more people on the right-hand side of our risk score line than SEB, our 1.0 risk score line. The PEB population, though, the non-Medicare population does include non-Medicare retirees, and that subset tends to be higher risk, so it does shift our risk score a little bit higher in PEB than SEB. And then finally, for both PEB and SEB, we see that the UMP populations are slightly higher risk than the non-UMP group. Most of this is likely driven by Achieve 2, UMP Achieve 2 and SEB, and UMP Classic and PEB, which have the highest share of members, but they're also very rich plans with broad networks. And that type of plan is likely to attract members or a larger portion of members who are higher risk or have higher risk dependents, people on their account and their families that they expect to use more services. Next slide. Finally, this is my last slide. We wanted to bring back this chart from 2022. I presented this at the retreat, and this shows the trend in net funding rate between 2014 and then projected out to 2025. The net funding rate represents the total non-Medicare cost for PEB benefits, so it excludes our surplus or deficit position, and it's a useful measure of actual program spending. The blue bars show that the annual net funding rate has increased year over year since 2014, although there may be some years where it didn't increase as much. And it's expected to continue to increase through 2025. However, the pace of that growth is actually modest. It's kind of a modest growth or a moderate growth. The solid line represents the year over year change, so how the net funding rate is changing each year. And you can see that distinct spike in 2021 after we had the contraction of utilization in 2020. We saw a rebound. And then if we look at the average trend, that's the dotted line. It's actually in the lower single digits. It's around 4.1%. So year over year, it might look kind of volatile, but if we take the average across the period, there's evidence that we're managing overall program cost trend very well for the PEB program. It doesn't mean, though, that we can't expect costs to increase, and that's just a reality of being in this healthcare space where we have secular trend, population growth, these things impacting our overall costs, and they're not things that we can necessarily change in a given year. That concludes my slides. I am available now to answer questions and also available by email if anything comes up as you kind of digest this information.
Molly, thank you very much for that comprehensive review. I see that Tom has a question. Go ahead, Tom. Tom, I don't think you're coming off mute.
Yeah, I'm sorry. Molly, can you go back to the first slide, the annual total non-Medicare cost? And so that slide is reflective of your non-Medicare cost.
Oh, just one above.
One more back.
Yeah.
Okay, so that is reflective of active SEP and PEB employees, is that correct?
This is just PEB, and it's an approximation based on the bid rates each year, and then we use the AV calculator to approximate the out-of-pocket spending. So this is just PEB UMP Classic Tier 4, which is a family with a subscriber, spouse, or state registered domestic partner, and then children.
And Molly, both active employees and non-Medicare retirees.
Correct.
Well, that was my next question. So it does lump together both the active and the non-Medicare people.
Yes, so that they are included in a single risk pool.
Okay, and then can you go to the 2023 employees monthly medical contribution breakdown? That one. So when you look at it, those are for active employees, I'm assuming.
It's the same here. So this is well, yes, this is for active employees because a non-Medicare retiree would pay a different rate.
Right. And
yeah.
The next slide is for Medicare retirees. So there is no slide for non-Medicare retirees.
Correct.
Right. I guess I do have some questions about that, but I'll wait until the very end of our session and ask those people to go in directly by. So thank you.
Yeah, of course. I think Kurt had a question.
Yeah, go ahead, Kurt.
Thank you, and thank you, Molly, for your presentation. I had a question on your last slide regarding the total spending trend. And if you explained it, I missed it, I apologize. But the categories on the left and right side, can you explain a little bit about what those are and what they mean?
Yeah, so on the left, the dollar figures you see is the actual net funding rate for the program, and then on the right, those percentages represent the trend for the net funding rate. So the dotted line hovers just around that 4%, 4.1% trend if you average across the period. And then the solid line is year over year, how the net funding rate is changing. Does that help?
Well, yeah, yes, but it's a percentage of what on the right side?
Of annual change.
Okay.
So for instance, if you have about an $800 net funding rate in 2014, and then it bumps up to just over 800, what that percentage change is between 2014 and 2015.
Got it, thank you.
Michaela, go ahead.
Yeah, thank you, Molly. I have two questions. On slide 6, where we're looking at non-Medicare cost drivers going up, do you know if the increase in pharmacy cost is related to the cost of drugs going up or the usage or like number of prescriptions filled going up?
That's a great question. I want to say typically it's all three, but I would defer and we can go back because we get a lot of information from our TPA MODA on those pharmacy trends. So I'd want to go back and examine them a little bit more because they break down each of those categories, and I can bring that back. But it is typically a combination, and in any one year there may be one area that's driving more of that. If there's a new drug that's introduced, if other drugs are going off patent, if there are specific, health conditions such as, COVID, that type of thing can impact that. But I can bring back a deeper dive on the pharmacy trend specifically.
Thank you. And then second question on slide 10, the non-Medicare risk profile. When you talk about kind of the factors of risk, has there been any movement to apply an equity lens to how we're looking at how risk is associated to different populations?
Can you repeat that? Did you say salary?
No, like thinking about kind of the risk profile and understanding that data can be biased if we do kind of like a historical backlook on how we're assuming risk. Has there been any change in how we're looking at what the risk factors are to think about kind of adding an equity lens to it?
Oh, interesting. So you mean the specific variables, like if we're assigning risk based on age, gender, diagnosis, type of thing?
Yes.
I don't think that the methodology has changed, at least not in recent years that I'm aware of, but again, I would have to look into that. We have our actuaries help us with risk adjustment and assigning this risk score. There's a model that they use, and I know that they've been using a new tool, but I don't know if it incorporates new variables into how we develop that per enrollee risk score. So I can definitely look into that. That's an interesting question. I think that could be valuable information.
And Michaela, this is Sue. I'll just add that we have an equity officer here this is an area with our clinical quality team, and all the payer work that's being pushed is really being revisited and looked at, and so it's an ongoing kind of journey. I know Milliman does have some of this, but the methodology, the way we do and don't capture data, this whole kind of risk arena in view of the DEI kind of movement is really shifting. So it's something that I'm certain that will continue to come back to the board. I think we have Monica next, and after Monica we have on deck Elliot. Go ahead, Monica.
Yeah, this is just to piggyback onto the previous question, not just around how the risk score is calculated, and I understand that the data that you are presenting is what the current pool is. Given the changes though in repro that's very dynamic and moving over time, I highly have to suggest that we, and I'm hoping the team is really on this in terms of that risk score. But as we start to think about the different trends that are going on both nationally and at the state level specific to reproductive health, rights, and justice, I'm really hoping that we can also start to predict, to think out what are the things that members may need given the loss of road, but then also like the changing dynamics in terms of what's going on in at least for reproductive aged individuals and childbearing families.
Yeah, thank you for that comment, Monica. Really important because, again, this is an arena that is so rapidly escalating and the needs are changing, and there are just so many dynamics and variables there. So that'll be another future content area for us as we continue to really support all the reproductive rights needed. Elliot, you're next.
Yes, I just want to say I had trouble hearing Michaela. I don't know how that is fixed, but I did really want to hear what she had to say.
If I take my mask off, is this better?
Yes, unfortunately, yes.
And Elliot, I think, both Monica's point and Michaela's point about just the ongoing need for so much greater understanding in the DEI and risk score implications. Again, this is an area that Milliman is and our agency are really in lockstep on, because we know that as COVID laid bare, and now as many other unfortunate trends are occurring, the reproductive rights, there are just things that we have to start layering in so fundamentally different to understand and predict this area. So there'll be so much more coming back to this board on these issues. Other questions from board members? I'm not seeing any, so I think with that, I think we're going to keep moving forward. I think we're going to forego our break at this point and just keep pushing through. So I'd like to invite Sarah Whitley, who is our PEBB Finance Manager, to take us into our next agenda item, which is Hearing Instruments Benefits Overview. And she's going to provide an introductory overview on hearing instruments. Her materials are behind tab 8. Sarah, welcome.
Yes, thank you, Chair Birch and members of the board. My name is Sarah Whitley. I am our Employee and Retiree Benefits Finance Unit Manager in our Financial Services Division. And you often see our finance team presenting rates or budget updates, but just as Molly's presentation demonstrated a few moments ago, another really important aspect of our role is using our plan claims experience to keep track of trends and utilization, and using that data to identify possible areas of opportunity, which is what brings me here today. We've identified a possible opportunity for more effective plan management in UMP related to our hearing instruments benefit. Next slide, please. So I'll start today with an overview of how hearing instruments are covered in PEB, and PEB today, so current state. This summary slide includes the current benefit design for hearing aids and routine annual hearing exams for our non-Medicare members. I do want to note quickly here that this summary is not applicable for over-the-counter hearing devices, which we won't cover during today's presentation. So you'll notice that while there is some variation in member cost sharing related to the annual hearing exam by carrier and by plan, the common thread across all carriers and plan offerings is that all plans offer coverage of hearing instruments at a $0 member cost share every 5 years. This next slide here features the current benefit design for hearing aid coverage for our PEB Medicare retirees. Next slide, please. Here we see benefit limits applied in our Kaiser and United Healthcare plans on the Medicare population, with retirees paying any amount over $1,400 per year every 60 months in the Kaiser plan offerings, and anything over $2,500 combined for both years in the United offerings. Again, however, we see UMP covers the full cost of hearing instruments for members every 5 years. And while these first two slides feature our current benefit design today, historically coverage levels have looked a little bit different, especially in our self-insured UMP plan offerings, which will be the focus of our conversation today. Next slide. So prior to plan year 2021, the Uniform Medical Plan allowance for hearing instruments was a total of $800 every 3 years for either 1 or 2 hearing aids. And that means that a member was provided reimbursement for up to $800 for hearing instruments every 3 years. Any costs over and above that $800 were the member's out-of-pocket responsibility. Based on what we know about the average cost of a hearing instrument, prior to 2021, most members obtaining hearing instruments were paying significant amounts out of pocket, suggesting that that $800 was not set at a sufficient coverage level. During the 2017-2018 legislative session, Senate Bill 5179 passed and required coverage of hearing instruments every 5 years for PEB and SEB employees and their dependents. This legislation resulted in our current benefit coverage levels for hearing instruments in UMP, which effectively provide full coverage at $0 member cost share for up to 1 instrument per year with hearing loss every 5 years. So while the effective date of the legislation that was passed under Senate Bill 5179 was January 1, 2019, implementation of this mandate was subject to budget appropriation, which wasn't included for PEB and SEB until the 2020 supplemental budget. The 2020 supplemental budget included adequate funding based on our original cost projections for a 2021 plan year implementation date. Leading up to that implementation in UMP for the 2021 plan year, Regents engaged us regarding some network concerns, including limited access to hearing aid providers, especially on the east side of the state. There were concerns that network waivers would be required for members seeking care in areas with limited access. They also engaged us on allowed amounts. Regents was unable to operationalize a specific allowed amount for UMP, and therefore the decision was made that billed charges would be paid in lieu of an allowed amount for hearing instrument claims to ensure that our members received adequate and timely access to these services. As a quick reminder, when we talk about allowed amounts, this is the amount that represents the maximum dollar amount a plan will pay for a service performed by a provider, and is typically a negotiated dollar amount between a provider and a health plan. A billed amount represents the full cost of a service as billed by a provider, and it's not tied to any negotiated or contracted rate. I'll use both of these terms throughout today's presentation. Next slide, please. So following implementation, we've taken a pretty deep dive into our UMP claims experience. And information gleaned from the data, along with the background and context related to how this benefit change was implemented in UMP, really helped us identify 3 key areas of focus, which you'll see here on this slide. The first is induced utilization following implementation of a fully covered benefit. As coverage levels increased in UMP, utilization of these services also increased significantly. As we've already discussed, this is likely because prior to 2021, the benefit limit of $800 total was not at a level to provide sufficient coverage for hearing instruments without members paying significant amounts out of pocket. Once coverage levels changed to provide full coverage of billed charges in UMP at $0 cost share to members, utilization of these services increased by more than 300% beyond our original projections. And this indicates at least some level of suppressed demand for hearing aids prior to 2021. The second area of interest is payment of billed charges in UMP. Coupled with that significant increase in utilization in plan year 2021, these billed amounts have led to significant increases in unit cost in our uniform medical plans. On an order of magnitude that's more than double what was originally projected for this benefit, which we'll see in much greater detail here in the coming slides. And finally, our third area of interest here is because UMP is paying billed charges for hearing aids, there's no incentive for our members or our providers to avoid those excessive cost options. Based on our market research, the cost and types of options available for hearing instruments can vary pretty significantly. A standard offering generally costs between $1,500 and $2,500, while a more high-end model with bells and whistles that might not necessarily be medically necessary can cost significantly more. Since 2021, we've seen claims for hearing aids paid as high as $16,000 for a single member. And without an incentive to seek out more cost-efficient but still medically effective options, UMP will continue to pay for these more expensive and, again, not necessarily medically essential hearing instruments. So that brings us to some of the data that supports those findings. So as noted on our previous slide, utilization and unit cost have been identified as 2 key drivers in UMP. On the left-hand side of your screen, we have a summary of total unit counts by plan year for both our PEB and SEB populations. PEB Medicare is the lime green bar on the graphic here. PEB non-Medicare is the bright blue bar, and SEB is represented by that gray blue bar. And you'll notice that prior to 2021, UMP experienced fairly modest utilization of hearing instrument benefits with around 2,000 units provided per plan year. And we used our historical benefit experience in our original modeling for the projected impacts of Senate Bill 5179 in UMP. Due to this, we didn't anticipate any extreme increases in utilization following implementation, which we see here was simply not the case. During the 2021 plan year, we saw more than a 300% increase in utilization, with most of that increase appearing in the PEB Medicare risk pool, but still significant increases if we look across PEB non-Medicare and the SEB program as well. I do want to note quickly here, the data included on the graph and in the table on the right-hand side of the slide for 2022 only includes claims that were incurred and paid through September of the 2022 plan year. So it's an incomplete look at the data. It seems as though we're seeing utilization return to pre-2021 levels, but because of the lack of claims run out, we're likely to see utilization levels that sustain an increased trend in 2022. On the right-hand side of this slide, I've included a table with the average UMP paid amounts per distinct member who received a hearing instrument in each plan year. And again, you'll note that very obvious difference in the plan paid amounts from 2019 and 2020 to 2021. Which brings me to our next slide. This slide provides insight into year-over-year annual paid amounts for hearing instruments. And Molly's presentation included a very similar figure in her select service trends section of her presentation, so it should look fairly familiar. We clearly see that stark increase again in plan paid amounts following implementation of the benefit change in 2021 with payment of full bill charges for hearing instruments across all of our programs and risk pools. Again, the majority of the increase in plan paid amounts appears in our Medicare population, where we're also seeing higher rates of utilization. And this is to be expected as our members age and require those assistive listening devices. In total, PEB UMP paid more than $33 million for hearing instruments in plan year 2021. Our original projections, based off of Senate Bill 5179, assumed total annual paid amounts to fall anywhere between $1 million and $2 million following implementation. So very different in reality what happened during plan year 2021. And these insights gleaned from our analysis of claims experience and utilization really indicate there's a real opportunity for cost containment in UMP across both PEB and SEB programs for hearing instruments. Next slide, please. So our next slide here provides a more granular level breakdown of UMP paid amounts, this time by cost range, which you'll see there listed on the left-hand side of the slide. Each bar representing program and risk pool provides a count of distinct members with a claim for hearing instruments that fell within that cost range during the 2021 plan year. And what I find most interesting about this slide is the significant amount of variation in UMP plan paid amounts. The amounts vary from a lower range of between $0 and $4,000 per member claim to greater than $9,000. And there's nowhere we can point on the slide to say, there's that range where members typically seek out. There's just really significant variation in UMP plan paid amounts for members. Next slide, please. And this brings us to our last look at the data. This slide features a summary of plan year 2021 highlights for hearing aid coverage. Under the current full coverage benefit, members can receive 1 or 2 hearing aids every 5 years based on their needs. And one of our very first questions when we were digging into the data is, well, how many hearing aids are members typically receiving? And it's very clear from the 2021 claims experience that members are receiving 2 aids much more often than members receive 1 hearing aid, with 83% of our claims for 2 hearing aids in that plan year. The average UMP paid amount per distinct member, again, is hovering right around an average of $6,000, indicating that on average, UMP is paying about $3,000 per hearing aid. So given what we've covered and some of the insights gleaned from the analytics, the main takeaway from our time today is that unlimited coverage in UMP has led to unanticipated levels of healthcare spend for hearing instruments. And as a self-insured plan offering, we know that UMP premiums are developed based on the total projected amounts required to cover all benefits provided to members. And as healthcare cost liability increases, upward pressure is placed on member premiums. We believe we've identified an opportunity to adjust our purchasing strategy in UMP that could place downward pressure on premiums for non-Medicare and our Medicare members in both our PEB and SEB programs. And today's presentation was really intended to set that foundation for a future discussion. We're currently exploring what a few proposed solutions could look like, which I'll bring with me to our next board meeting in April. And also, as Dave and Cade have mentioned, there's been some renewed focus on hearing instrument coverage during this year's legislative session. We are closely watching House Bill 1222, which addresses hearing instrument coverage, and we'll keep an eye on how that bill progresses in the coming weeks. Dave, is anything to add, or are there any questions?
Sarah, thank you so much for that very comprehensive foundational presentation on hearing instruments. So I am not seeing any raised hands at this point. This topic will definitely come back to this board in the future, and we look forward for you to report, you and Kate, to report back on 1222, as well as to come back with some proposals of how we can contain these costs. I see that Harry just raised his hand. Harry, go ahead, please.
Yeah, sorry to break in. I'd like to have a curiosity question. I don't know how relevant it is, but I'm just curious. As I understand it, the hearing aid traces back to Senate Bill 5179 from a few years ago, and my curiosity is how the fiscal note that was attached to that bill or stacked up to the reality as we've seen now projected 3-4 years later. Thank you.
Yeah, thanks for your question, Harry. I tried to highlight, probably not very well, some of those differences in today's presentation, but I'm happy to bring back a more detailed description of those differences the next time we meet. The main takeaway is that our original projections were much lower than what actually took place in 2021. I believe we projected around $1 to $2 million in total annual spend, with 2021 actual planned paid amounts topping more than $33 million for PEB. But again, happy to bring back some of those more detailed information later. And Dave, I don't know if you have anything you want to add.
I don't need it anymore. Thank you. I appreciate it. I think I recall seeing that now, and I just forgot it. Thanks.
Well, Harry, there's one other piece that was in the fiscal note that I think is illustrative as well, is the unit cost. So the cost of a hearing aid was projected as $3,000 for a set. And what we're actually seeing in reality is, on average, $3,000 per ear. So there's a doubling factor there from a unit cost perspective as well. That's a big difference. So that overall amount of spend and unit cost both had claims-based information that drove the fiscal note, and then reality kicked in at quite a different experience on both of those components.
Thank you for that additional information. Sarah and Dave, one of the things that I'll be keen to see also is the impact of hearing instruments going over the counter and pricing, and how we were kind of, that timing intervened with some of this unfortunate kind of spending. Fortunate in that hopefully these devices are warranted and effective, but I think there's a lot of variation in these products, so I look forward as you all bring back more of that definitive information.
Absolutely, Chair Birch. We were planning on talking about over-the-counter aspects. Sarah highlighted at the beginning that wasn't part of today's, but it is part of the mini-series on hearing aids presentations. I will note that one piece on over-the-counters is we know that it is for moderate to mild hearing loss and does not include severe hearing loss. So that's just, there are nuances like that, but we'll be going over the counters in April.
Great, thank you so much. So with that, I think we ought to just do another quick 5-minute stand break, bio break, and then we will reconvene for both our last two items. Actually, our Medicare update will come after our break. So thank you again, Sarah. Board members, we're going to take a quick 5-minute break and reconvene at 11:35. Go.
Reese.
We are continuing our PEB board meeting. I'd like at this point to ask Ellen Wolfhagen, our senior account manager. She is back with us today to share the latest updates on work in our Medicare portfolio. Ellen's materials are behind tab 9. And Ellen, welcome. And Dave and I were definitely representing you in Washington, D.C. last week, but I know you have both you and Dave have lots to share with us today. Go ahead, I'll turn it over to you.
Thank you, Chair Birch. Good morning. Good morning to members of the board. My name is Ellen Wolfhagen, and I work in the portfolio monitoring and management part of the division. I'm here today to talk about, next slide please. Yep. Three things, activities that have gone on since our last meeting. An open enrollment issue that we had with United Healthcare, an update on the comments that were submitted to CMS, and an update on the Stakeholders Medicare Coalition listening session. Next slide. As part of our regular weekly contract management discussions with United Healthcare, we go over enrollment issues. And they brought to our attention a system glitch that they had on their side, which caused enrollment files to show the wrong effective date. This glitch affected all of the UHC plans, not just PEB, and they identified 283 PEB program members who were impacted. I'd like to point out that 283 is less than 5% of the over 6,000 new enrollments that we had during this time. And this glitch occurred during the federal Medicare enrollment period, which made it a bigger impact as well. Next slide. Corrections were made to all records in early February. The corrected effective date was January 1, 2023, or in a very few cases, December 1, 2022. Enrollment is retroactive to the correct date, so nobody lost any coverage. If there were any claims impacts, United took care of that, and United sent out letters to all the impacted members on February 8th. There is in your appendix a copy of the generic letter, obviously without any specific information. Next slide. As a reminder, CMS proposed rules that were issued on December 14th, 2022. I spoke in some detail about these during the last meeting. The rules are aimed at strengthening Medicare Advantage plans and those plans' protections for enrollees, and also at aligning Medicare Advantage with traditional Medicare and significantly controlling marketing of Medicare Advantage plans. The comment period closed on February 13th. Next slide. HCA submitted comments on February 13th. We covered these topics: prior authorizations, especially the proposed rule of ensuring that prior authorizations last as long as the treatment. Marketing and communications, this is generally speaking on the individual market MA plans, but to avoid confusion. Enrollee notification requirements for Medicare Advantage provider contract termination. Part D formulary changes and provider directories. And a copy of the comments is included in the appendix for reference. Dave, do you want to add anything?
Yeah, I just wanted to highlight again that the rulemaking that was published by CMS was over 500 pages. So we as an agency picked a select number of things. Obviously a two-page letter can't possibly get into 500 pages of detail, but picking some of the most salient points and areas that we are hearing from retirees over the last year, and just taking an opportunity to chime in on supportive ideas and refinements of parts of those rules. This is also where I wanted to take a moment to highlight a little bit more detail about the meeting with the CMS administrator. And it was 2 weeks ago. Time moves really fast. It wasn't last week, at least as far as I can remember. It was 2 weeks ago. But we did have that opportunity, and I wanted to highlight that some of the other topics, a little bit more granularity about what we discussed. We were really started first and foremost describing the subsidy structural disadvantage that exists for coordination of benefit plans versus Medicare Advantage plans. That is really kind of the hallmark of what we've been describing for the board and the public the last couple of years as to that structural limitation in the Social Security Act that requires an act of Congress to change how CMS can flow subsidies out. It is specific to Medicare Advantage and Medicare Advantage Part D plans, but we were describing and showcasing how that plays out in a portfolio for the dollars that retirees then ultimately pay for different types of plans and describing why there are advantages and disadvantages to different plans and why they might be preferred by certain retirees. So really taking that opportunity to bring to the attention in the forefront that subsidy structural issue. We did also highlight a little bit about our rulemaking comments, and CMS obviously when they're in rulemaking can't be really super responsive even in an in-person meeting, but really highlighting the marketing practices that happen with Medicare Advantage and how that creates a lot more confusion in the market, whether it's for an employer-sponsored MAPD program like our benefits or ones that are on the individual market. And so really highlighting that, and in addition, a phrase that I have become more and more familiar with that a year ago I certainly didn't know is Irma. I thought Irma was a hurricane, and it is, or was, but it's also a significant financial penalty that can happen for a lot of retirees, and there's not kind of a lot of notifications and awareness of the impacts of that and when that can be triggered, and so some encouragement to take some extra time and space to do things about Irma notifications is another area that we highlighted. We continue to highlight that there's a lot of flexibility in employer-sponsored programs, which we're very supportive of, so that we could bring a benefit that was as close to the Uniform Medical Plan Classic for members who felt that they needed another lower cost option that was very robust in coverage. And that is really afforded by the flexibility that exists in federal rules and law on employer-sponsored programs, but also asking for more flexibility, highlighting a question that has come up a lot in the last year about provider directories. We highlighted how challenging it is for Ellen or myself or anyone at HCA to say, it's great to start with the online directory, but in order to get the insights about providers who give non-Medicare covered services, you really got to call because it can't be in that online provider directory. We were highlighting that, and now we're trying to really work on some clarifications with CMS about how people were interpreting rules and guidance and seeing if there's a way to break that logjam so that it is really members would be able to rely on the online provider directory. So that's an area that we were highlighting and we're continuing to have some discussions about. So I just wanted to highlight some of the key messages, and I want to turn it back over to Director Birch or Chair Birch for other aspects.
I will just acknowledge too that the administrator asked us some very specific questions too about some of the very public articles about, for example, the Snohomish Health District retirees that were dropped and uncovered and the changing dynamic there. There were questions that were asked of us also about some of the negotiation issues that Dave alluded to earlier between Regents and Optum and some of the just experiences that we were having here in Washington. You know, there are 11 other states that are in this sort of predicament we are in with our retirees. And so I think it was really important for them to hear Dave's perspective of all of these variables at play and the collisions and challenges for our members navigating MAPD and Medicare and the complexity. So I think from a federal perspective, they have a very different look about what they're doing for cost containment and the elevation of MAPDs, and from a state implementation perspective and all the subsidy differentials. It was very good that Dave was able to really do a deep dive. So,
and just to tack on, we will be bringing later this board season some insights. When Sue just mentioned 11 other states, there's 11 total states that have, with ourselves included, so 10 other states that have coordination and benefit plans, and we plan to bring some information to the board about kind of a survey of states and an evaluation of other state plans to help the board understand the context of where other states are on this issue. So just preview of coming attractions, there's 10 friends in this, 10 other states that are friends in this game with us, and we'll be sharing some more information about that later in the board season.
I do want to reiterate, and really in defense of both Ellen and Dave, we're caught in this web that is a federal issue, but it really is impacting us and playing out here. But I think there are some that believe here in Washington we are driving this policy direction. We are trying to mitigate kind of the implications of federal policy. So again, I think the fact that our federal partners are willing to listen to us and hear from a state perspective is really good.
David, I wonder if you could talk a little bit more about Irma.
Yeah, and John, you're first, and then Elliot, you're on deck. So
Okay, sorry about
there's your first question, Dave. Can you
And
talk a
Ellen's
little
going to
more
be my
about-
ventriloquist.
So let me explain about IRMA. IRMA is the income-related monthly adjustment amount. It's based on the retiree's income. Every year, Social Security looks back 2 years on tax returns. If an individual makes more than, in this year, $97,000 in those past 2 years, or as a couple, $194,000, then they have to pay this IRMA adjustment. That adjustment is calculated against their Part B, like boy premiums, and Part D, like David premiums. One of the areas where there is confusion is if people were on a Medicare plan with creditable drug coverage, remember not Part D, but similar to Part D, at least as good as, they paid their IRMA on Part B premiums, the medical premium, but they didn't have to pay it on the drug because it was not a Part D plan. If those people move to a MAPD plan or they move to a Medigap plan with a separate Part D plan, now they are under Part D and have to pay a Part D premium, and the IRMA gets calculated against the Part D premium as well.
Complicated.
It is complicated, John. But does that answer your question?
It does, but how does that impact our retirees?
So if our retirees were, for example, on UMP Classic Medicare, that's a plan that has creditable drug coverage. So if their income was above the level set by Social Security, they would have to pay IRMA on their Part B premium. Remember, all Medicare retirees in PEB have to pay their Part B premium separate from the premiums they paid HCA. They would not have paid a Part D premium for UMP Classic Medicare, but if they switched to either an MAPD plan or a Medigap plan, Plan G, with a separate Part D plan, then they now would have to pay that IRMA against the Part D premium as well.
You know, I know it's got to be a very small portion of our retirees, but I'm wondering if we shouldn't do some outreach or some education so they understand it.
Yes,
Because it is very complicated.
It is complicated, and we are doing a lot more. One of the issues is we don't have information to identify people's income levels, so we don't know who is paying the IRMA because it's paid directly to Social Security, but we can definitely improve our education about all of this. Thank you.
Thank you.
Elliot, and then Tom, you're next.
Thank you for, on page 5, talking about the proposed rules that CMS has. I was wondering if you could send us a link at these rules that aim to strengthen Medicare.
Absolutely, we will make that available.
And then my second question is, while I appreciate your discussions with the people at CMS, when I looked at the letter that you submitted, it doesn't include a drug subsidy for a federal drug subsidy for our self-insured plans like UMP. And given Dave's comments, did you think this was not a salient issue? I personally, I think it is, but please explain.
Elliot, the agency was responding to the topical areas that were promulgated in the rules by CMS, and we didn't identify that it would be responsive to a specific part of the federal rulemaking that was proposed. But we did take that opportunity when we were in person talking about a wide range of issues. So typically when you're providing public comment, either whether it's to the state or to the federal government, it's usually limited to the topics in which that rulemaking is set out to achieve. And so we didn't see it as readily identifiable to, although it was a voluminous rulemaking packet of 500 pages, didn't see something that really lended itself to talking about the subsidies in that particular comment letter that was targeted to responding to the rulemaking topics. It'd be like if the agency promulgated a rule about vegetables and you wanted to talk about cheese, it just wouldn't be relevant to the topic that they're seeking public comment on. So we take the opportunity where we can, and we did with the in-person. It's not that it's less important, it just wasn't deemed as readily identifiable as a responsive to that rulemaking topic.
Okay, thank you, I understand.
Yeah, and I'll just say, even getting Dave in the room, this was a big deal because typically Medicare is, they have their own agendas. This is a minor issue, 11 state type of issue. I know it's a major issue for us, minor for them when you look at their national kind of profile. And we have to be very careful, Elliot, to get back in that room regularly. We play certain chits and we know what things to talk about. So I'm sure we'll be back at them, and they have visited us here in person, as you have been told in prior times. So it's important for us to manage that relationship carefully. Tom, I think you are next. Go ahead.
Yes, thank you. Where it says CMS comments and CMS issued proposed rules on December 14, 2022. The rules are aimed at strengthening Medicare Advantage plan protections, aligning more with traditional Medicare, and controlling the marketing of MA plans. Could you explain that in a little more detail, what those mean?
Sure. So in terms of strengthening the protections in Medicare Advantage plans, so that's aimed at things like prior authorizations and making them more comparable to how they are handled under traditional Medicare. So that's part of making it more in alignment with traditional Medicare. There are some other particular things about strengthening the plan's protections for enrollees, and I can certainly provide more information next month about that.
Yes, I would love to hear that. Thank you. And then what about the controlling the marketing of MA plans?
So in terms of the marketing, CMS is very concerned about misleading marketing, celebrities making endorsements about Medicare Advantage plans. This is what you see on the individual market. And there's a lot of confusion. There's a lot of, you pay $0, you don't have to pay anything, but the fine print is you have a $10,000 maximum out-of-pocket limit, which is very difficult for a lot of people to meet. So CMS is really concentrating on those kinds of ads and looking very closely at it. And it's also worth noting that in this state, although the Office of the Insurance Commissioner does not have jurisdiction over Medicare Advantage plans, they do receive complaints about marketing of those plans, and they do address those complaints. Again, those complaints are really about the individual market Medicare Advantage plans, not about PEB plans.
In the interest of getting through our meeting, I'm going to ask that Ellen always come back and rejoin us. Ellen, thank you so.
She has a little bit more.
Oh wait, I'm sorry. Go ahead. Real quickly, and then we'll move on to Stella.
Yep.
Okay. So I'll go quickly through this. The Stakeholders Coalition, I'll just mention that in your appendix there is a cover letter, and it shows the different members of the Stakeholders Coalition, so I won't go through those. We had a pilot listening session. It was scheduled for 12 people. One of the people with Kaiser Medicare Advantage unfortunately did not participate. And next slide. It was a 90-minute virtual session. I will say people were very enthusiastic and active in participation. The enrollment in plans varied from about 2 months to 27 years. For the pilot, they were all PEB members, so we didn't have anybody who was managing somebody's care. And next slide. The key questions, what do you like about your current plan? What could be better? I do want to note everybody had at least one good thing to say about their plan. And a lot of what could be better had to do with customer service at all levels, and concerns about open enrollment and our staffing, as well as the plan's customer service. Next.
We will be bringing back to the board after the entirety of the listening sessions, comprehensive overview of the feedback. Ellen's just trying to keep us back on time. We will be doing comprehensive feedback review.
Yeah, this is just a high-level summary. In the appendix, the listening session guide is included. Next slide, please. Here's a schedule of the listening sessions, 4 of which will be in person. Tumwater on March 29th, Cheney on April 11th, Yakima on April 12th, and Bothell on May 16th. And the HCA website is used for registration. Next slide, please. Just a very brief overview of public forums. There'll be 3 of those, 1 in March, 1 in April, 1 in May. They will be virtual. There's an opportunity for up to 30 speakers. Again, registration will be handled through the HCA website, and there'll be 3-minute time slots for speakers. That's it.
Thank you, Ellen. I know you and Dave have really done an extensive process with this reach out. It's really, I think, the greatest number of people you've reached out to in a long time. So thank you very much, and we look forward to you coming back and updating us again. All right, let's move now to Stella Nye, our roles and policy development agenda item. Stella is our policy and rules coordinator, and she's here to introduce some policy resolutions. As a reminder, because these are the first resolutions for this board season, they are being introduced for initial discussion and feedback, and no action will be requested on these today. Her materials are behind tab 10. Stella, welcome.
Thank you, Chair Burge. Thank you, Chair Burge. Good morning. Members of the board, for the record, my name is Stella Ng, and I'm the Policy and Rules Coordinator for the PEBB division. Sorry, I should move it closer. Today, I have 2 proposed policy resolutions being introduced. This slide and the next 2 slides are included in the presentation, so you will have them available as you consider the policies we will discuss. Slide 5, please. Thank you. So here's the 2 proposed resolutions being introduced. The first resolution addresses when a subscriber has a change in residence that affects medical plan availability, and the second proposed resolution addresses Medicare Advantage and Medicare Advantage with prescription drug plans involuntary disenrollment. Our goal today is to introduce these policy proposals to the board, get your initial insights, and prepare the board to take action at the next board meeting. Next slide, please. The first proposed resolution, PEB 2023-01, addresses when a subscriber has a change in residence and do not make a plan change when their medical plan is no longer available. This proposed resolution allows HCA to disenroll the subscriber and the dependents from the current medical plan when they no longer live in the plan's service area and enroll them in a medical plan as selected by HCA. Under state law, an enrollee must live in the medical plan's service area. Our current PEB rules already allow a PEB subscriber who has a change in residence that affects health plan availability to switch plans. We need to update our rules to require subscribers to change medical plans if the medical plan they're enrolled in is no longer available based on a change in residence. And it reads, Proposed Resolution PEB 2023-01, when a subscriber has a change in residence that affects medical plan availability. After a change in residence, the subscriber must elect a new medical plan if a subscriber's current medical plan is no longer available based on residence. If they do not elect a new medical plan within the time period allowed by special open enrollment rules, the subscriber will be enrolled in a PEB medical plan as designated by the director or designee. And we have two examples to illustrate this board policy proposal. Example number 1. John lives in Snohomish County and enrolls in Kaiser Permanente WA Classic Plan. In September 2024, John moves to Vancouver in Clark County. Because John no longer lives in a county where Kaiser Permanente WA Classic Plan is available, John must select a new medical plan. What happens if John fails to elect a new medical plan during the special open enrollment period when his current Kaiser Permanente WA Classic Plan is no longer available in the county where he lives? If John does not elect a new medical plan within the time period allowed by special open enrollment rules, he will be enrolled in a PEB medical plan as designated by the director or designee. And we have a second example. Example number 2. Marsha lives in King County and enrolls in Kaiser WA Medicare Advantage Plan. In September 2024, Marsha moves to Arizona. Because Marsha no longer lives in a county where Kaiser WA Medicare Advantage Plan is available, Marsha must select a new medical plan. What happens if Marsha fails to elect a new medical plan during the special open enrollment period when her current Kaiser WA Medicare Advantage Plan is no longer available in the county where she lives? If Marsha does not elect a new medical plan within the time period allowed by special open enrollment rules, she will be enrolled in a PEB medical plan as designated by the director or designee. And without this resolution, if she does not change plans, CMS will disenroll her from coverage after 6 months.
Quickly, I just wanted to give an example of why the language gives the discretion for setting the plan by the director or director's designee is because there's so many different variables. Example 1 involves a member who's in Kaiser and moves to another part of the state that also has Kaiser plans but not the same regional plans. And so to be so plan specific in the resolution wouldn't afford that flexibility. The real goal would be to place them in as comparable and as close to a plan as possible. If they're in an HMO, then identify the best HMO plan that's comparable in that area. If they're in a PPO, UMP is broadly, this scenario shouldn't come up for UMP because of its broad nationwide access, but that's why there's not a specific plan identified as the automatically enrolled plan. It's to be able to account for those differences, but the goal is to put them in as comparable plan as possible.
Okay. So this brings to the second proposed policy resolution. Proposed resolution, the next slide please, sorry. Proposed resolution PEB 2023-02 addresses when a subscriber is involuntarily terminated by a Medicare Advantage or Medicare Advantage with prescription drug plan. Under federal rule, there are limited circumstances where a subscriber will be required to be disenrolled from a MA plan or a MAPD plan because they are no longer eligible to remain enrolled in the plan. For an MA plan, if someone lives outside of the plan's service areas for over 6 months, the MA plan must disenroll the subscriber. And for the MAPD plan, an example would be if the subscriber enrolled in that plan and the member fails to pay their Part D IRMA, CMS will require the MAPD plan to disenroll the subscriber. And Ellen and Dave gave a good description of what IRMA is, so I wouldn't really reiterate that, but I wanted to stress that for some of our retirees, particularly those who are newly retired, may fall under this IRMA threshold, and they may not be aware of getting that premium notices from CMS. And so if they're enrolled in one of our UHC MAPD plans and fail to pay their Part D IRMA to Medicare, CMS will notify UHC to effectuate the disenrollment. And we're bringing this proposed resolution to the board so we can enroll these members to another medical plan as appropriate. And the proposed resolution reads, Proposed Resolution PEB 2023-02. When a subscriber is involuntarily terminated by a MA or MAPD plan. When a subscriber or the dependent must be disenrolled by a Medicare Advantage MA plan or Medicare Advantage prescription drug MAPD plan as required by federal law. The subscriber and the enrolled dependents will be enrolled in a PEB medical plan as designated by the director or designee. The new medical plan coverage will begin the first day of the month following the date the MA or MAPD plan is terminated. And we have an example to illustrate this proposed policy resolution. Bob is enrolled in UHC PEB Complete and has not been paying his Part D IRMA. At the end of July 2024, CMS disenrolled Bob from the plan as required by federal law because he fails to pay his IRMA to the government. So what happens next for Bob's coverage? Bob will be enrolled in a PEB medical plan as designated by the director or designee, effective August 1st, 2024. And are there any questions from the board members before we go to the next steps?
What haven't we been doing up to this point? What's been the procedure?
I think that's John.
Oh, yeah, I'm
Go
sorry,
ahead,
it's
Stella.
John, yes.
The procedure for which policy resolution?
The one we're talking about now, what has been the procedure that we have followed?
On the situations that we are aware of, we've got notification from the plan to disenroll the member.
But we haven't re-enrolled them in anything else?
We did.
Yeah, John, this is really a protective measure to make sure that as we identify anybody, to make sure that somebody isn't inadvertently out of medical and thus loses their PEB retiree eligibility possibly forevermore. This is really a protective measure to reinforce what we've been doing in instances, depending on the timing of the notification. If we have to move fast to avoid somebody losing eligibility, making sure that there's clear authority to do that. But we've tried where possible to work with the member to identify as quickly as possible what plan to put them in, but this just gives some more flexibility and reinforces if there needs to be quick decision to avoid somebody losing their eligibility in totality. We can do that, and then if the member decides that the plan that they're automatically enrolled in doesn't meet their needs or they don't want the coverage, we can cancel it then, but it just preserves, it sets up a better opportunity for success for a retiree not losing their eligibility.
This is Michaela, more of a comment than a question. I appreciate the examples, and Dave, you kind of proactively answered my question, but I think like knowing that this is a public document, I think it'd be helpful if you had the, like, Bob will be enrolled in the closest comparable PEB medical plan or something like that, just because I could see myself going to like worst case scenario of like, are you gonna put me in the most expensive one? So just adding that in there to give people peace of mind.
Thanks for that feedback. We can certainly do that in examples.
Great.
Thank you. And are there
Go
any
ahead,
other
Stella.
questions from the board before I talk about the next steps?
Not seeing any.
So for the next steps, we will incorporate any board feedback in the proposed policy, and I wanted to introduce a new stakeholdering process for the PEB board policy development this year. We're leveraging SEP stakeholdering process and incorporating that same process to the PEB board for gathering feedback on proposed policy resolutions. And just to give you a little bit more detail about how that is being utilized, we typically allow 10 calendar days for collecting feedback so staff can adjudicate comments in time for the board vote at the next board meeting. And an email will go out tomorrow to our stakeholders for feedback. And other interested stakeholders or members of the public are welcome to submit their comments regarding these two proposed policy resolutions. And we have a new email address set up, is HCA PEB SEB board policy feedback at hca.wa.gov. And they can submit their feedback by March 20th. Thank you.
Quickly, I want to also let the board know, we review the feedback from either, whether the member is SEB or PEB, a stakeholder, we look at it in totality for both boards. So I just want to remind people that the public, that we do that as well. We're doing a similar stakeholdering right now with the SEB proposals, some of which are mirrors of these, and they have other proposals that are specific to their program. But we do look at the feedback comprehensively from either or both boards. And although we kind of automatically anticipate in our planning process, anticipate that we would bring a resolution back at the very next board meeting, that's kind of our status quo. If there's feedback that comes in that really suggests that we need to scrap and start over, we will do that. We will not just bring something to the board and say, there are all these problems, but we think you should pass something. We will come back at the next meeting and say, we actually, shelve that resolution for these reasons. I just don't want the language that Stella was just describing seen as presumptive that everything will always get a vote in its exact iteration as presented. We often have policy changes or something happen, but we do set up our process for planning purposes that absent significant feedback or changes, it would be planned to be voted on at the next meeting. So I just wanted to describe that for members of the public who might be listening in and wondering if there's a presumption. No, it's just our planning processes that we've been doing for years in the program.
Thank you, Dave, for that explanation, and Stella for your presentation. I really want to commend both of you for also establishing the email feedback. I know in some of the correspondence that we received in the last month, it was brought to our attention that it wasn't easy to submit kind of email feedback. So we now have, again, for the public, the HCA PEB SEB board policy feedback at hca.wa.gov. So another way to get feedback to us, if you're more comfortable with written correspondence. Thank you, and we'll see you back next month, Stella.
Thank you, Chair Bush.
And for members of the public too, Stella's contact information is on the slide there, as Dave has pointed out. We are now at the time for public comment. This is our general public comment period for this particular meeting. The amount of time provided to each member can vary, and I ask that the members that want to speak keep their comments to around 3 minutes. And if we get a big queue of folks, we might need to adjust that time. I think we only have one so far. And I'd like to call on Helen Shawcraft. I believe she has had her hand up. I'm hoping I didn't delay her from a topic earlier. And then if there are others of you that are on Zoom that would like to provide comments, I'd ask you to start signaling by raising your virtual hand. So Helen, I am turning it over to you to identify yourself, who you are affiliated with, and please state your public comment.
Yeah. Thank you, Chair Birch. And first of all, kudos to you, Chair Birch, for keeping the meeting on track. And second, thank you to all of you for having the email addresses of where the public can send their concerns. My question really relates to Ellen Wolfhagen's presentation about the listening sessions. I am a retiree from the University of Washington, and I am on the UW Retirement Association board. I wanted to know if there would be listening sessions made available to retirees who purchase their medical insurance through the PEBB that are not members of the organizations who are part of the RPEC Medicare Coalition.
Hi, Helen. This is Dave. I can answer that question for you. We have I believe it's after the pilot, 23 listening sessions that are scheduled between now and May. The coalition partners are doing the primary recruitment for those listening sessions. We do have the information about them publicly available, and the registration process is on our website. So there's not a prohibition of anyone, but we are trying to give prioritization in the registration process to the coalition partners who have helped establish those meetings. And I will take back your general question and be in touch about the nature. There are a variety of stakeholders who I think could be interested, and I'll follow up or have someone from my team follow up after the meeting about kind of your specific request. But our registration process is on our website, and the coalition partners are responsible for the recruitment efforts in general.
Okay, thank you. We actually, the UW Retirement Association discussed this yesterday at their board meeting. There are 10,000 retirees at the University of Washington to which we have access, and I know they would like to participate, and I know you have contact information for the staff at the UW Retirement Association, so contact would really be appreciated.
And yes, Helen, I'll also say that as we get close to the listening sessions themselves, if there are spaces that are available, each listening session is set for 12 people. We will reach out to various organizations. The Healthcare Authority will work to supplement and ensure full participation for the sessions we've set up. So we will reach out to various organizations, and we can include UW retirees and your team on that, as well as the agency looks to supplement any open positions that aren't filled by the coalition's recruitment efforts.
Okay, thank you very much. I appreciate it.
Next, I'd like to call on Amy Fortier, and then Ms. Smith, you'll be on deck, and then Sally Holt after that. But go ahead, Amy, if you'll open up your line, identify yourself and your affiliation.
Thank you, Chair Birch. Amy Fortier, Sequim, Washington. I am a member of the Retired Public Employees Council and did have the chance to participate in the pilot listening session. And I want to thank the Healthcare Authority and the board for the opportunity not only to participate, but in offering this communication capability for all of the subscribers, and look forward very much to the results and then recommendations that come forward from all of that data. Again, I urge everyone to participate who has an opportunity, and thank you for that. And a quick thank you for your advocacy at the CMS level. It is very challenging to dialogue, I would think, with someone at that level for the kind of change that we want and need. However, appreciate your efforts there, and also appreciate knowing about the 10 other states. I think that gives us then 11 attorney generals and governors, and 22 senators, and any number of representatives who perhaps will help us with the changes that are needed at that level. Thank you.
Amy, I will pass on your gratitude and accolades, and we'll keep working with this current administration, who has a very gracious open door policy to the state of Washington. Ms. Smith, you are next. Sally Holt, you'll be after that, and then I'm adding Thesvi Cashin. So if you'll just be ready to speak, go ahead, Ms. Smith.
Hi, my name is Jay Smith. I'm a retired special education and biology educator from the state of Washington. I'm also a stroke and leukemia survivor, on a good trajectory because of life-saving medication that my classic enrollment offered me. I want to thank, I had a really quick education on how insurance works in the last couple of months, and I want to thank anyone involved in supporting these programs for retirees, because obviously in my case, it was life-saving. I don't know if this is the proper forum for my own issue, that I'm going to briefly describe it and then you can tell me where to go from there. On January 15th, I received a termination notice on my supplementary insurance plan, and which at that time I didn't know what it covered exactly, but it was frightening because of course I am in a remission right now and I depend on my drug, which is also very expensive, which probably won't make me very popular in this room. I received that termination notice, and luckily I found Mark Cuban, who his business was able to supply me with the drug I needed, and at from a $2,500 a month to I pay him $35 a month for my medication. And so these are all really complicated issues, and that's a good example of how confusing and kind of crazy it is in the environment where a patient has to try to navigate. I requested information on how to reinstate my PEB enrollment per policy 56-1, and I was told I needed to go through an appeals process and provide a doctor's letter and supporting materials, which I did. I faxed those to the PEB office, and I did that, and then I received this invitation to this meeting, and that's the only communication I've received, and I don't know where to go from here. If this board is who would hear my story, or if I need to present my story elsewhere. I've already sent it on paper per fax.
So Ms. Smith, first off, thank you for your years of public service in education. So first and foremost, thank you. But also, we're glad that you are doing better, and we will have a member of our team reach out to you for follow-up. And we won't do that in this public process, so we have your information. And we will be, after this meeting, I'm looking at our operations director, Jean Bowie. She is texting as we speak to have somebody contact you. So thank you for bringing this issue forward, and we will be responding to you this afternoon.
Thank you so much.
Keep healing up. You're doing great. And Dave and I presented in we were part of a national presentation about Mr. Cuban's efforts to bring affordable drugs forward. So we'll be following up with you on that as well. Next,
thank you so much.
You bet.
It's been an awesome experience to find out.
Great. Sally Holt, you are next in the queue, and then last, Thesvi Cashin. So Sally, go ahead and open up your mic and identify yourself, please.
Okay. Can you hear me okay?
Yes.
Great. So yes, my name is Sally Holt, and I'm a recent retiree. I worked both in the K-12 system as an educator, and then lastly spent my last few years at a community college. So I was also a state employee, so I'm duly enrolled in both programs. And probably like Ms. Smith before me, I'm trying to determine the best place to be able to inquire about something I'm faced with, as well as many of my colleagues who are not yet 65 and eligible for Medicare. However, we're in that area where our choices for medical coverage with PEB are limited and growing much higher in the UMP, especially the classic plan. So I did talk with Ellen Wolfhagen a little bit about that. She suggested to bring this forward to the board. When I looked into the listening sessions, it appeared those were really more catered to people who were retiree but also Medicare eligible, because it refers to Medicare plans, which I can't participate in yet for a couple of years. So as an example, what happened to me was that I had been watching UMP premiums go up, and I understand the rationale and what you guys are caught with because of the prescription increases. However, what happens to me is I was a person who was very comfortable to be on a medical plan with a little higher deductible or out of pocket costs because I don't need a lot of health care at this point. However, when I wanted to go into PEB coverage upon retirement, I was really looking forward to it because we paid some retiree premium over the years and it's good coverage. And my dad, my brother had all been in it. What I learned really quickly that because my husband is 65 and Medicare eligible, for him to go into that program, I was limited into, because he did go into the United Healthcare plan, I was limited to only UMP Classic or Kaiser. And that premium, as you know, has gone up considerably. So then I was faced in 2023 of paying close to $800 a month just for myself, then my husband's premium and his Medicare. So what I was wanting to propose or talk to, if there's ever been any discussion or interest in, since we have providers like Premera and now United Healthcare, is there a way to offer coverage to those of us who might be 62, 63, 64, who desire a plan and to be pooled in with the state, but we don't necessarily need the classic plan and the higher costs with that? And so that's really my question. I just talked to another teacher colleague last night and the same thing. She's just really upset at the limitation because her spouse is also 65.
Sally, thank you for those comments. We do open up and receive bids occasionally for other options. And let me take your comments back to our staff who are listening in. We'll discuss this and see if there's anything we might be able to do about having a bid offering for other options. And Dave, I don't know if there's anything else you want to comment on at this point.
Just the one piece that I would add is we did spend 2 years, I believe it was, I can't remember which 2 years it was now. I don't know if it was 2020 and 2021 or 21 and 22, looking at options to possibly migrate over some plan designs that are in the SEB portfolio that are not currently in the PEB portfolio. And we brought information in the public meetings as well as sometimes in executive session with some of the proprietary information. And that ultimately, there was at least 2 years of discussion about trying to leverage those contracts and some possible plan options. And for a couple of different reasons, it did not, that proposal or those ideas really didn't pan out into producing competitive products in the PEB portfolio. So I did want you to be aware that we did look at some of that in the context of our contracts that we went out for procurement for SEB, but that doesn't prohibit us from looking at either again or looking at other options for additional procurements. But I did just want to raise awareness that there was an acknowledgement of the differences in those portfolios, especially people who are coming from the current K-12 system where there are additional options, and it just didn't pencil out financially to be competitive in the PEB portfolio. That was at least the analysis at the time. So I just wanted, we're aware of some of that choice concern. I just wanted to highlight that as an initial, not final response.
Sally?
Yeah, no, I appreciate that because again, just like with United Healthcare, I talked to a lot of retirees who were just, you can't drop UMP, you can't drop, again, it was a lack of information, right? So yeah, I am interested in knowing if cost benefit, if that was the case, it just wasn't viable. Because there's several of us, as you know, who spent a lot of time in the system as retired educators who may not need the UMP Classic, but we don't have a choice unless we go to Kaiser and then lose our providers. So is there somebody specific who could reach out to me about this, or making contact?
We'll identify with you here at the meeting. We'll identify the best person to continue that discussion with you. We'll reach out to you. We have your information. You said you spoke to Ellen, so I know we have your information.
Yeah, and I can send a follow-up. I'll send up just to make sure that I'll let her know that I did speak today. So I really appreciate your time.
And Sally, this is Director Birch. I do want to just acknowledge the coverage complexity that is occurring in the United States is becoming so much more difficult to navigate. And so this conversation is also occurring at the Washington Health Benefits Exchange about populations of folks needing insured, as we're seeing certain districts drop coverage for young retirees, I like to say. I don't mean that. I just, early retirees, I know you've been working hard all these years. This is just an area, these are things that Dave and I conveyed to the CMS administrator about the complex coverage designs that are becoming more and more non-navigable for people like you and for people like us that have to put up these plans and made commitments. So we stand with you, but it is important for you to know that the Health Benefits Exchange is a group that you might want to kind of start watching more of. You might want to watch the Healthcare Cost Transparency Board that is starting to lay these things bare as people have a greater understanding of the complexity of what we're trying to do, but we really appreciate your comment. So we'll be following back up with you.
No, and I appreciate you listening. I know how complex it is. It's just, for those of us that served along, we just looked forward to, right? We didn't get paid a lot over the years, but our benefits were key.
Yeah, and as the healthcare costs have crowded out so much more and affecting retirement benefits, it's all playing out not the way things were designed or intended, and it's very problematic. We need to move on, but we'll be back in touch with you. Thesvi Cashin, you are our last public comment today. Go ahead and open your mic and identify yourself, and then board members, I just beg your 2 more minutes from you.
Hi, thank you for accepting me to speak very briefly. My name is Thesvi Cashin, and I'm a retiree from Seattle Colleges, and I have elected to use UMPs during and since my retirement. I unfortunately couldn't listen to the entire presentation today, so forgive me if this question has been answered. Is it true that the UMP Classic Plan is going to be dropped at the end of this year?
No, that is patently false. It will not be dropped at the end of this year, nor does the board have any plans to drop it. We are trying to defend all of our options and offerings while we are also trying to curtail escalating healthcare costs.
So we won't see such a huge increase in future years as what we...
No. Let's clarify. We cannot control the cost of the mushrooming price on UMP as the plan continues to have more members choose to migrate elsewhere. Costs will continue to go up. That is outside of our control. I'll have Ellen Wolfhagen reach out to you to have a deeper conversation because we are very concerned about what will continue to happen with the price of the plan.
Okay, thank you very much.
All right.
That's all I have to say. Thank you, and thank you for the meeting. Goodbye.
Thank you to all our commenters. If there is anyone else in the room, I hate to cut you off, but please provide your comments in writing to us or contact Dave or myself. You have all our email information. Board members, a few closing thoughts. The 2023 board season schedule is posted on the HCA website, and it's always part of every briefing book, which is normally posted to the website the Monday before each meeting. Our next meeting is April 13th, 2023, from 9 a.m. to 1:30 p.m. with the same format. Attendance can be in person or via Zoom. We do love to host you in Olympia, though, so if you want to come in, great. Same for the public. Dave, agenda items or any final comments before we adjourn?
As we wrap up the meeting, I just wanted to highlight at the next board meeting, by then there will be chamber budgets from the Senate and the House. So Tanya will be here to describe the state of the budget proposals and how they relate to the governor's proposed budget. Kate will be back with bills. So those are 2 key topics. And the last thing I wanted to acknowledge, because this has happened since our last board meeting, many of you, even at the retreat, interacted with Dr. Emily Transu. She was the Associate Medical Director in our clinical care quality transformation team that was working heavily with the PEB and SEB program for the last few years. She has left the agency and went on to Co-Imagine, which is an entity that our former CMO for the Healthcare Authority had migrated to, and now he retired, Dr. Lessler. So I just wanted you to be aware that Emily has transitioned away from the Healthcare Authority. We'll be doing a recruitment for another Associate Medical Director, but I just wanted you to be aware of that significant change of someone who regularly interacted with the board. And thank her for her service.
Yep, Dave, thank you. And on behalf of the entire board, I think we'll draft up a letter and ask you all to give us your electronic signatures to thank her. She will be sorely missed and has been a dedicated public servant. And she will be working with us externally, but we hate to see her go, but she's really done an amazing job here over the years. I'm going to now adjourn this meeting. Thank you, board members, and stay well. We'll see you soon. This meeting is adjourned.